බේරගෙන ඉවරලා ඉන්නකොට මට ඒක ඇතුලේ ටිකක් වෙලා ඉන්නකොට දැක්කේ කොට්ටාව තමයි මේක තියෙන්නේ මේ බිල්ඩින් එක මාව මරන්න හදන තැන කියලා හිතිලා බැලුවාම වටපිට කොට්ටාව නගරය වගේමයි ගස් කොළන් ඒ බිල්ඩින් ඔක්කොම පේන්නේ කොට්ටාවේ නගරෙ තිබිච්ච ඒවාමයි. ඊට පස්සේ මම ඉමීට හිතාගත්ත මෙතනින් කොහොම හරි පැනලා යනවා කියලා. පැනලා යන්න හදනකොට මට මේ කට්ටිය වට කරලා ඉවරලා මා බිම දාලා ඉවරලා මට එක්කෙනෙක් ගහලා බිම දැම්මා. දැම්මට පස්සේ මා වැටිලා හිටියා. ඉන්නකොට මම අර බේරගත්ත කට්ටිය දකින්න නැහැ අනිත් කට්ටිය දකින්නත් නැතුව ගියා. ඊට පස්සේ මාව ඒ බේරගත්ත කට්ටිය දකින්න නැති වුණාට මට ඊට පස්සේ කල්පනා වුණා මම මේ කරන්නේ මොකද්ද කියලා. ඊට පස්සේ ටිකෙන් ටික මට හොඳ වීගෙන එනකොට මට මතක් වුණා මාව ස්පිරිතාලෙට ගෙනිච්ච ඈතට ස්පිරිතාලෙට ඒ ස්පිරිතාලේ තමයි ඉන්නේ කියලා ඉවරලා ටික හොඳ වෙනකොට ටික මට කල්පනා වුණා මම ඉන්නේ ස්පිරිතාලේ තමයි කියලා මතක් වුණා.
Right. So that's what a patient who had been delirious recall of that episode. So you see how he was disoriented. He thought he was at Casberger, and then he felt people were sort of trying to kill him. He was trying to escape. He was very agitated. And gradually he got back. He knew where he was. So he got oriented to time, place, and person. He was so disoriented that he was disoriented to place also. Disorientation to place goes off last. Okay? Right. So with that, we come to what are the causes. Now we see that someone's delirious. It could be hyperactive, it could be hypoactive, it could be mixed. So what are the causes for delirium? Some of the common causes are infections. Any type of infections can cause delirium. Even a viral infection can cause delirium. Right? Withdrawal from certain medications, sudden withdrawal from certain medications, even withdrawal from alcohol causes delirium. Acute metabolic states, diabetes, someone who has got cardiac issues in a metabolic state can get to be delirious. Trauma, then obviously CNS pathology, hypoxia, deficiencies, endocrinopathies, acute vascular accidents like CVAs can cause delirium. Toxins and the other drugs are also known to cause delirium. And now you'll be doing a talk, Dr. Amilisru will be doing a talk on, I think, alcohol and illicit substances. Now you'd see more and more patients not also abusing methamphetamines and other substances. So these drugs are also likely to cause patients to in delirious states. Right, so what I have put in red are very, very common things. So look out for those. So when someone presents like this, it is important to think, am I dealing with the acuteness of the onset has to be thought of. And then your differential diagnosis would be, are we dealing with dementia? Are we dealing with schizophrenia? Because of the psychotic symptoms, the mood symptoms, are we dealing with depression, anxiety? Or are we dealing with both? Is delirium superimposed on dementia? So both can also happen. So you have to look out for that. So hopefully your final year exposure in the psychiatry unit and the medical units and surgical units would have will help you identify delirious patients, right? So what I want to say is you have to think of delirium early on. Don't exclude everything else and then suddenly think, this is delirium. Okay, so both can happen. And think of delirium. Don't miss delirium. Before you call the psychiatrist, think about it. So, okay, so how do we manage this? That's one of the most important things. So I'll be talking about how you can prevent. Part of management is prevention also. Identifying and treating the underlying cause, changing the if they are delirious, non-pharmacological methods we can use, pharmacological methods we can use, and what we could do post-discharge, what we should be doing post-discharge. Okay, so prevention, how to prevent, identify, treat, change environmental factors, pharmacological things, and post-discharge. So how do we prevent? Way of prevention is obviously identifying or targeting risk factors. Make sure they sleep, they get good sleep. Sleep is important, right? Elderly people who come, keep reorientating them. The time is this, today's date is this. Have a big calendar. 3 times a day, reorientating is good, at least. In that a group which I said who could get delirious, time, date, and keep telling them where they are. You are at this particular ward, you are in this particular hospital. If you can, what you could do is do a cognitive assessment. And this, I told you this clinical assessment of delirium scale, that is there, but you might as well do a clinical assessment instead of using questionnaires. Now that questionnaire I don't think is validated in Sri Lanka. It's not going to be anything different, but clinical assessment is more than enough. And of course, active management of a patient who is delirious. Now, when it comes to now we think the patient is delirious. What we have to do is the non-pharmacological things is you have to educate the family about this, because suddenly the family sees a very quiet, placid person getting very agitated. It can unnerve them. They're very sort of shocked. So tell them, this is due to this condition. It will resolve once this infection or whatever subsides, right? So involve a family member or a carer. Clear communication has to be given to the patient. Talk loud, because there could be hearing impairments, and talk very clearly, very briefly. Don't give long harangues and explanations. So in the environment, have reminders about day, time, and again, identify yourself, identify him. Try to have staff consistency, because they're delirious. Sometimes they might not be able to they'll misidentify people, and with that there could be persecutory delusions which are formed. So have a consistent staff. This set to manage this patient. Now it's easily said than done in a busy setting to do this, but try as much as possible to limit the staff who's going there. So a designated nurse, a designated doctor, the healthcare assistants, that will be useful. And other thing which you have to do is try to manage them in a quiet room. Okay, that is also very important. Not in a busy setting, not right in front of, they have to be looked after, but not in a very busy medical ward where people are rushing. It doesn't help them. A quiet, calm place, but under observation is what is important. And we have to prevent this sensory deprivation. So if they wear spectacles, if they have hearing, if they If they use hearing aids, walking aids, give it to them. Make sure they have them. All right, that's important. So what we do in the environment, you have to avoid extremes. You should overstimulate them, as I said before, that is manage them in a, right in the middle of the ward, busy ward, casualty day, that's when they'll also turn up. Neither should you be understimulating them, right? So you have to find the balance. They have to have adequate space and sleep. As I mentioned before, a single room is ideal, but under observation. The lighting shouldn't be too bright. It shouldn't be too dark. And sound also, it shouldn't be too loud there. You know, where vehicles, your ward might be next to a main road. You can't stop the vehicles going, but you have to try to make it, try to close the windows or ensure there is adequate ventilation, but minimize sound or noises as much as possible. And make sure you make them walk also. Just because, say, hypoactive delirium, sometimes they want to lie in bed. So you have to ensure that they're ambulant. Now, this is where we get the physiotherapist to come and help so that they can walk around. Sometimes you may have to use restraining. If they're severely delirious and agitated and you can't manage them, you might need to restrain them. So soft restraints is what you have to do. But try to manage the other environmental factors to reduce this agitation and aggression. Okay, so least restrictive methods is what you have to look for. So when it comes to pharmacological use, generally what they say is you control the agitation. There are times you have to use pharmacological and environmental things. Environmental things have to be done. If the agitation is a lot, what you could use is a small dose of haloperidol because we don't want them sedated. Okay? Small dose of haloperidol would be like 0.75 milligrams, maybe twice a day or 3 times a day. So you have to play it by ear. You don't give a big dose of haloperidol like treating a schizophrenic or a manic patient, a high dose. Quetiapine is also recognized, a small dose like 12.5 milligrams or 25 milligrams. Those are options, right? We try and avoid benzodiazepines as much as possible, especially because they are old. Now, delirium tremens is managed in a different way. But delirium due to other causes other than alcohol is managed using this, avoiding benzodiazepines. Because you have to remember, it's the old person who gets delirious. The brain is sensitive. So you don't have to load them with high doses, right? Sleep is important. If they are not getting sleep in the night, promethazine, Phenergan, 12.5 or 25 milligrams is adequate, or quetiapine in the night is also adequate. Don't give multiple drugs because that makes things even more difficult. And try to stick to small regular doses and you titrate according to response. And review the patient at least twice a day or 12 hourly. Okay. Now, this is managing the delirious part, but you have to find the cause of delirium. What is the cause for this? You correct the cause. If it's a hyponatremia, you have to correct the sodium levels, right? If it's an infection, you have to treat vigorously. So whilst treating the cause, these are ways of managing the other behavioral aspects. Okay. So mobilizing the patient is important. So what do we do post-discharge? Now patient gets well, then we slowly can stop the tail of the haloperidol. Once the infection or whatever settles, you'll see the behavior also changing. Then we slowly tail off the medication. So we send them home, and you have to advise the families and caregivers. You have to advise them and support them. Because, you know, seeing a patient agitated is quite difficult for the family member who's seeing the patient very calm and quiet. Right? So you have to tell them this is due to this reason. Okay. And you have also to tell them, next time you come, if you see this type of behavior, bring the patient early or talk to your doctor about this early on and inform the ward or whoever, if you have to be admitted, if the patient has to be admitted, that this happened the previous time. So look out for this early signs of behavioral changes. That is, it could be agitation, or they could be slowly going into hypoactive delirium, right? So if there's a fever, act fast. Now, sometimes the symptoms of delirium last longer than the underlying condition. Now, infection is settled, but the delirium is, the behavior changes are still there. They won't be at that intensity as before, but they'll be still there a little bit. So that is because of the brain, right? The brain is the sensitive brain. And post-discharge, when you get them to come for your review, it's good to do a MMSE, that's a mini mental state examination. On discharge, and you get them about 6 months after also. Because delirium is also another cause for patients to be getting dementia. Okay, any questions? Now that's the end of the delirium talk. Is there any other questions you want to ask on this? Or shall I move on to this? So presentations of organic illness, what we basically want, you have done this in your final year. What we want to tell you is certain other disorders can present with psychotic features, with depression, with mood disorders such as depression or mania or anxiety. So always don't think, just because they present with hallucinations, there is a psychiatric illness and this sent to the psychiatrist. No. In your differential diagnosis, think, could it also be could it be an organic illness? Epilepsies, especially TME, might present with tactile hallucinations or visual hallucinations. Head injury, encephalitis, uremia, uremia can all present with psychotic features. So you have to think, is this also going on? Again, depression, people with depression, CVA, cerebral vascular accident, depression is common. Same with epilepsy. Hypothyroidism, again, depression is common. Cancers, patients presenting with alcohol misuse disorders, depression is common. And also, what you have to know is people after an MI, there is a higher chance of them getting depressed. After a CVA, there is a higher chance of people getting depressed. And myocardial infarctions and depression, it's bidirectional. People who are depressed can also get MIs, and people after an MI can also get depressed. Certain drugs also can cause depression. So you have to think of that. Those are the causes. Again, steroids can induce mania. It can induce a depression after that. It can make people get delirious. Antidepressants, INH, used in management of TB, cannabis, cocaine, again, all these things can cause. After that, what we have to think of is anxiety disorders also present with these, like epilepsy. Alcohol also can present as an as an anxiety disorder, or it could coexist, right? So my point here is these presentations can present as organic illnesses. So keep that in mind. Do you have any questions for me on management of delirium, or because we have, I think, another 4 minutes to go, I think. I'd be happy to answer any questions if you have. Are there any questions you'd like to ask? Okay, so thank you very much for patiently listening to me, and enjoy your internship and don't miss delirium. All right, okay, thank you. I'll leave the meeting.
Right. Thank you very much, Madam, for that comprehensive lecture on delirium. So next up is an interesting lecture by Dr. Sairu Pereira, senior lecturer and consultant psychiatrist at University of Peradenias, on topic of counseling patients and breaking bad news. So over to you, Madam.
Okay, thank you very much. Just waiting for this slide to load. So until it loads, let me just thank the college and the ministry for organizing this. It's a pleasure to be here as always. I think this is third or fourth consecutive year that I'm doing this lecture. It's a pleasure as always. Okay, so the good news is, hopefully you can hear me. The good news is my lecture is a very short one. So you have to pay attention for approximately 35 minutes, maybe less than that. Okay. So from what I understand, just having a little bit of trouble with my slides. Okay. Can you see this? So in a few months, not few months, no, in a few weeks, approximately 3 to 4 weeks, your default setting 24 hours will be like this. Okay. You will be deprived of all other entertainments and luxuries, unfortunately. So get used to that. So this will be you. This will be you in much heavier wards, much busier wards, right? So this will be you in 3 to 4 weeks' time. Now, this is what it will feel like. It will feel like you're writing notes, taking calls, examining patients, right? It will feel like 2 hands and 2 legs are not enough, and that there's not enough time in 24-hour clock to get through all the things you have to do. So therefore, wouldn't it be easier if you were just replaced by a robot, right? Robots don't need to eat, right? They don't get tired, right? They can run very fast, and they can probably clerk patients and get them to draw blood and measure blood pressure. All of that, I think, would be done by a robot if the robot was to replace you. However, there's a certain thing that a robot will not be able to do, right? So far, from what I understand, robotics is not so developed that you can get a robot to actually think or feel what the other person may be thinking or feeling, isn't it? I don't think technology is so advanced that we can afford to replace a robot or replace you by a robot, simply because this is something that we really value in a doctor, this empathy. Okay, what is empathy? Empathy is being able to understand and feel I'm putting it very simply, right? Understanding and feeling what it must be like for the other person. And interestingly, there is an area in your brain that gets highlighted. If you do an fMRI, that brain area gets highlighted the moment you are engaged with some sort of empathic related behavior. Right? It's called the S1 region. So it's not just something that psychiatrists have created. You may think that psychiatrists all we say is empathy, isn't it? It's not like that. It's actually a very good reason why we say that. So there's an empathy center, and the importance of that is empathy is a virtue that you must have when you counsel patients and you break bad news to patients. So this is what we will be talking about today. So this is why we cannot at the moment afford to replace you with a robot, because we believe that as doctors, as medical students who have now become doctors, who are going to be doctors, you are full of, or at least you are better equipped with this virtue or this skill of empathy, because you're going to need that when you counsel and break bad news to patients. So my lecture is done in two parts. First one is counseling and the second one is breaking bad news. Each will take approximately 10 minutes. Okay, so it's not going to take long. And most of this, you know, in case you don't know who I am, this is who I am. I'm sure there's some of our products here online. So good morning to all of you. Nice to see all of you here. I can see some familiar names. All right, so moving on. Counseling patient, what do you mean by that? Right? Advice. This is how the word started. Consilium means to offer consultation or advice. Okay. What it actually means is giving professional guidance for personal or psychological problems. I think without us realizing, we do this all the time for our friends, for our colleagues, relations, isn't it? We do this, but when it comes to your patients, it is perhaps a little bit different. Let's see why that is. So counseling is a little bit like guiding a blindfolded person across a very busy room. The patient has to walk, but you can guide them. It's the patient's journey, patient's issue. You are giving a very good guidance to them. That's all you do. Okay. Have you heard this? A problem shared is a problem halved. When you share a problem with someone, it feels like that problem has reduced. Right? This is a very famous thing, and building on from that is when counseling started. Okay, it's been more than half a century now since this professional counseling has started. Okay, so it's actually a therapy that allows people to discuss and explore problems, thoughts, and any difficulties. Anything really. Our lives are full of these things, isn't it? Problems, thoughts, and difficulties. So it is you're helping your patient to discuss and explore these in a very safe and confidential place. You can't just do it corridors. You can't be doing this. So why do we need to consult them? Now, don't think that all patients who need counseling are patients with psychiatric problems. You don't have a mental health problem to need counseling. Please remember that. All our patients need counseling. Even you need counseling from time to time, let alone the patient, right? So patients don't have to have a mental health problem to need counseling. Patients are often very helpless. Okay, they're unaware of what they have. They're scared of what might happen. They are missing friends, family. And of course, in between all of that, you will also see patients who have had previous mental health problems or unhealthy habits. So all these categories of people need counseling. So basically every single patient that you see. Okay. What else are the benefits of counseling? Okay. You can prevent serious medical conditions. You can prevent complexities happening in obesity, diabetes, or whatever, heart disease. Right? You can coach them, you can educate them, guide them about their medication, about lifestyle modification, about self-monitoring devices, how to use the glucometer, how to, so various things. And patients who have been counseled properly, right? Patients who have been counseled properly by their doctor, the treating team, get admitted less. It's a known thing, right? And you make your patient very independent by making them self-sufficient. They don't have to rely on you all the time. So this is an additional benefit of counseling. But it's not the most easiest thing to do, right? It's not the most easiest thing to do. I'll tell you why. It takes time, okay? It takes time. It takes a lot of patience on your part, which I think most of you not having much of, I think, from what I have seen, right? You want to do things very quickly. This is not something, yes, you must be quick as an intern, but counseling patients is not something that you can sort of do in a few seconds. And some patients can be very difficult physically, mentally, right? You have to communicate properly. You have to use a combination of verbal and non-verbal communication, but you have to be calm and clear, right? You can't be judgmental, okay? You can't say COVID leda, TB leda, depression leda, okay? You can't be like that, okay? Because you become very judgmental the moment you step foot into the world. Don't be judgmental. You may become judgmental by certain things that patients tell you. If the patient says that he has HIV, or if the patient says he's homosexual, or if the patient says he has some other STD or something, okay? You cannot be judgmental and let that judgment affect your communication with the patient. Always remember, patients will tell you a lot of sometimes very, how do I say? They will disclose certain secrets to you. Very, how do I say? Things that may be very tempting to tell your co-HO, right? You want to tell some relationship problem or some sexual problem, right? Or it's some drinking problem in a person you never thought had drinking, right? So you want to go and tell, but you must never do that. You must be non-judgmental and maintain confidentiality at all times. And very important that you make the patient feel that they have been listened to. This doesn't happen sometimes, okay? Patient has to know that they have been listened to by you. Okay? So how long does it take? Of course, it can differ. Patient to patient, they're different, isn't it? You have to take it on a case-by-case basis. Usually, this counseling part is done by, it can be done by nurses also, but we expect the junior doctors to do the counseling part. And usually it is after the consultant has seen the patient, but generally, depending on the patient, time of 10 to 15 minutes on average. Remember that in some cases, it can take longer than that because, our patients come with extended family, isn't it? They will come with various other family members who also want to know what's going on, and they will be asking you various questions, and it will take time, and you can't say, I have to go sort of thing. You have to make sure when it comes to counseling, that you spend adequate time with the patient. Okay. Now, I know that most of you, isn't it? Because your prefrontal lobes are not completely mature yet. You're very impatient. Isn't it? When you're that age, we've also like that, right? So you think, oh, I can't be doing this. I have so many other important things to do. This is waste of time. Right? Because unlike a hernia, which you can take out, or a ganglion, which you can take out, or a cesarean section where you take out the child, you can't visually see an improvement. isn't it? And there's no way of measuring also. Can you measure the impact that your counseling has had? Is there a blood test? You can't. There's no analog scale or anything to see the end result. But patients who have been counseled properly, I think we mentioned it before also, by your team, by you or anybody else in the team, they have less admissions and they are more adherent to the treatment plan. And patients' quality of life, therefore, improves. So don't think that it's a waste of time, because the qualitative component definitely improves. So how can you master the art of patient counseling? Okay. Now, I'm also not an expert, but you get more experienced with age, I suppose. Okay. At the end of your internship, you will be much more experienced at counseling than on the first day. That's for sure. As are your other skills. Other skills also like that too, right? So every time you encounter your patient, all the way from admission right up to discharge, this educating patient has to start from admission right up to discharge and at every single encounter that you have with the patient. And always check what the patient already knows. Right? They may know certain things, then it's helpful for you to move on from there. And as much as possible, don't use technical terms. Okay, don't say you have decompensated non-alcoholic steatohepatitis or whatever it is, right? Make sure that you use simple terms. You can use Sinhala words, Tamil words, whatever that makes it more easier for the patient to understand. Don't think that you are this hi-fi person and you have to talk everything in technical language. Okay, so use simple terms. Layman's terms can make that. Terms that are not technical and not medical. And you can use visual aids. You can use leaflets. You can ask them to watch some video or whatever it is for them to understand things better. And ask the patient, this is going on from bullet 2, right? Ask the patient to explain their disease or treatment as they would tell it to their friends or family. That's a good way of checking whether the patient knows about his or her illness, right? When you give the medication, or when the nurse gives the medication or the injection or the tablet, make sure that you tell them, okay, this is for your blood pressure, this is for your joint pain, this is for your kidneys, you need to take this like this, drink it with water, blah, blah. Okay, so that when you give the medication, that is a good place for you to impart some knowledge about the medication and how they should take. And if they are having refills or something like that, how to use it, how to keep it, how to store it, all of that. Then, depending on what your patient is having, right, make sure that you give them signs and symptoms of an emerging emergency. If an emergency were to come, what are the things to look out for, right? And I always rely on technology, unlike when we were interns many, many years ago. Now technology has come into the picture, isn't it? So you can use technology to your advantage. YouTube videos, online various websites, right? And various resources, you can get printouts and keep them ready for patients. It's a good habit to do. If you are, now you have 3-4 weeks more, right? See whether you can get some small printed cards or leaflets done for the patient so that they can read how to take your pressure pills, how to take insulin, right? Things like that. Right. Make sure the patient's needs are addressed properly. The patient has some need or requirement. Don't just give them a stack of papers, right? And then go through the papers and go through the BHD and just show them some investigations. Don't do that. Make sure that the patient understands what you are trying to tell and any clarifications of any doubts that they make. Okay. So that is about counseling. And as promised, I kept to 10-15 minutes. Okay. Rest is also quite short. Breaking bad news. Now, this is a little bit more, needs a little bit more skill than counseling. Okay, I think when you are doing your psychiatry appointment, when you have the mocky, isn't it? When we train you for mockies, we have this breaking bad news station, isn't it? At least at Peradeniya we do that. And you have had lessons, I think, in your behavioral sciences where you have breaking bad news. So you know the theory behind it, right? So let's see any practical problems that may come across when you break bad. So what is a bad news? Any negative news really that affects the patient's future, right? Sudden negative news is what bad news is, right? Yeah. Like when we were trying to watch the Asia Cup final, isn't it? And we all sat down to see, leisurely to see, right? 26 for 4 wickets or something, no? So sudden drastic news that negatively alters. No, that is not breaking bad news. I'm just trying to make it a little bit interesting for you. Okay, so from a medical point of view, drastic and negative news that will affect the future of your patient. Okay, now you know that when patients come to hospital, even if they come to hospital for just a cough or a cold, you're always worried about death and disability. Patients are not MBBS people, no, patients are just lay people. Whenever they set foot into the hospital, they are always worried whether this will lead to some disability, some handicap, or even death. Not only the patient, but also close family and friends. Now, the reality about illness is that, you know, if you have worked in hospital wards, you will know some illnesses have favorable outcomes. A favorable can hond outcome. ප්‍රශ්නයක් නැහැ, කිසි ගැටලුවක් නැති හොඳ outcome එකක් some have, right? Some have undesirable outcomes. Prognosis is poor, diagnosis complex, right? That is the reality. So patient and the family needs to be informed. As a doctor, you must remember that you can't always be giving good news, especially when you're working in a hospital. Ultimately, there will be more instances where you're giving bad news rather than good news. Right? Remember that breaking bad news is a very, very important thing, and a patient has a right to know about his or her illness. So the family, if it is immediate family. Okay, and usually I say, breaking bad news is done by the most senior member of the treating team. But you know how busy our consultants are, how busy our senior registrars and SHOs are. So ultimately, most of the time, this may come to you. This may come to you, depends on your team and how busy you are. But even if it is your consultant, he or she started off like you, right? Because they started off like you, they also have been through this process. Okay. Must tell you this also, don't think that breaking bad news is only done by psychiatrists. Breaking bad news is done by whatever the treating team. If you want, you can have someone from the psychiatry team with you, but the news has to be broken by your team. Right? Please remember that. It's one of the, as a doctor, this is one of the most difficult things I had to do. Because we fear that we will be labeled as a bad person. You are the messenger, no? Right? Yes, the messenger of bad news. You don't want to be bad because you are worried. How will the patient respond? How will the family respond? And then when the patient may get angry, patient may shout at you, patient may suddenly cry, right? Patient may suddenly become very emotional. And then we are a bit uncomfortable because you don't know how to deal with that, right? And when you give bad news, hopes are gone, isn't it? If a patient had hopes about his or her illness, you are the messenger who brings this bad news and takes away the hopes of the patient. And we don't like to do that. But it's part of the package, and this is something that you will ultimately have to do. Okay? But if you have a good attitude, which is something you must have, and how clearly you give the message, and how privately how much of privacy you give, and how you are able to tackle the questions that the patient and family may have. It helps. Also, although it's a difficult task, if you handle it properly with a good attitude, communicate well, give enough privacy, and give enough time for patients or family to clarify questions, then that really works. Okay, now there are various protocols, okay? Various protocols on how to break bad news. There is no one proper way and one bad way of doing it. Whatever way is okay. I generally go away with this ABCDE mnemonic. There are various other techniques. So let's just run through this before I end my lecture. Okay. Right. A is advanced, or you can say advanced or advanced preparation. Before you go and break bad news, prepare yourself. Get the proper clinical information. Relevant, proper clinics is very important. You can't be fumbling with the notes and looking at this MRI and that one and turning books. Go there prepared, right? Arrange for adequate time in a private, comfortable location. That is why I said that at the beginning of the lecture also, this is not something you can do in corridors and canteen this breaking bad. Okay, so please remember, you have to have a private, comfortable place without interruption. Okay, there should not be interruptions. It's very rude if there are interruptions, and it looks very disrespectful. So there should not be any interruptions. Tell your colleagues, I will be here for 15 to 20 minutes with this patient and the family. If there are any emergencies, please handle it. Tell your co-HO or the nurses or something, anything that's not an emergency, right? For the next 10 to 15 minutes for other people to handle. Switch your phone off or leave it in silent or leave it with a colleague and mentally go through how you will deliver the news. Okay, otherwise you're going to look very stupid in front of the patient. So that's A, advanced preparation. B is build a therapeutic environment and a therapeutic relationship. Okay. You must figure out how much they want to know. Okay. Do you want to know the diagnosis, the full diagnosis and the prognosis? Or do you want to know it in detail like that? Right? When possible, in Sri Lanka, we are very close to our families. So if you feel that the patient is well supported by family members, when possible, you can have them also. Right? Make sure you introduce yourself to everyone present and ask for names and relationships to the patient. Very, very important. Especially remember the patient's name. For goodness sake, if you have forgotten the patient's name, don't tell a wrong name. It looks really horrible when you do that. Right? Foreshadow bad news. Foreshadow kiyane podi warning ekak denawa that you are going to give some bad news next. Right? So you introduce yourself. Right? Say that, I'm sorry, but I have bad news. Then ask them how much they want to know about it. Right? And that this is not just one meeting, that, following this, there will be several other meetings in a reassurance for you. C is very, very important. You must communicate the message properly. Okay, you must understand this A, B, C, D, E, some of it overlaps. Okay, but so B and C tend to overlap a little bit, but communicate well. Please, I'm reiterating this. Ask what the patient or family already knows and understands about the illness. And speak frankly. Frankly, tell the truth. Don't be hiding things. But not like a robot. Very compassionate in a very empathetic way. And please avoid technical and medical words. You are just going to lose the patient. They are going to disconnect with you the moment you start using highly technical medical words. Right? Absolutely no point doing that. So please avoid medical jargon and please expect and allow for tears and silence. The moment patients become silent or the moment they become tearful and cry, we become very uncomfortable. We become very uncomfortable, and then what happens? You just start to talk without any relevance. You just start to talk rubbish. Don't do that. It's better to not talk and you also just be silent rather than just talking unnecessary things there just because you are uncomfortable. We have trained you these things during the appointment, right? Hope you will remember this. And don't go really, really fast. Okay, go at a slow pace. Go with the patient's pace. Check that the patient has understood. Halfway through, right? Halfway through, I have forgotten to put it, it's called tailgating. Halfway through, you stop and say, so far we discussed about this. It looks like you've had it for so much of time. This is the situation that it is now. These are the complications. So next I'm going to talk about the management. But before that, do you have any questions up from what we have spoken up to now? Do you understand? So about halfway through, summarize and encourage questions. At the end also, summarize and encourage questions. That way, your patient has time to digest what you have been saying. Okay? And also, unless of course your patient is a consultant or something, right? And make a follow-up plan. Always say, look, we've spoken about this for only 15 minutes. There's so much more to discuss. And make a date and a time. Let's meet again on Friday between 12 and 1. I'm free. So if you can come at that time, we can maybe discuss whatever. Right? Be very clear and communicate. Not only the patient, you will have to deal with angry, emotional, distressed family members as well. Right? This is again something very, very difficult because so far you have been the star in the ward, right? You are the one who is running around and getting the blood and doing all these things. And suddenly you have become this person who is giving this bad news, and the family members or the relations who loved you so much suddenly may not keep you as their favorite person anymore. That's okay. So deal with it. Deal with patient and family reactions. That's part of life of an intern, okay? Assess and respond to emotional reactions. Be empathetic. You know how to show empathy. So not only to your patients, to the family as well. One of the things that doctors in Sri Lanka are very well known for is this showing empathy, right? When you go and work overseas, like me, right? When you come to my level of maturity, you will realize in other countries, they have to artificially do it. Whereas in Sri Lanka, these things come naturally to us, isn't it? We are a very warm kind of culture and society. Okay, so because of that, this won't be too difficult for you. Okay. Last few slides, encourage and validate. Validate means saying it's okay to be not okay with what you have just heard. Okay. So, encourage and validate emotions, offer realistic hope. Realistic, don't just to become popular with the patient, don't say boru things saying, oh, this is great and you'll be fine next. Okay, realistic hope. Even if a cure is not realistic, offer hope and encouragement about what options are available. For that, you have to be better prepared. That's why the advanced preparation is important, right? And discuss treatment options at the outset. Just give me a minute. I'm getting a call. Let me see if. Just give me Yeah, sorry. So what y'all do is y'all don't give a very realistic picture. Okay. So make sure you give a realistic picture, hope and encourage about the options, right? And treatment options, necessary referrals. And also remember to include about the spiritual needs. Okay, you may not believe in spiritual needs and emotional needs, right? Especially the spiritual needs for people who are slightly older than you, from older generations. They have a lot of value and faith in spiritual needs. So make sure that, I know you're going to be busy, but despite that, you make sure for any spiritual needs that the patient may have, and see what you can do from your point of view to support. Okay, so thank you. I think that's all we have for today. So good luck with everything. I'm sure you'll be fine. This is just a recap of things that you already know. But if you want to ask me anything, I can spend a couple of minutes to discuss any clarifications. Let me ask you this. If a patient is having some terminal illness, let's say, right? And if the patient is having a terminal illness and patient has 3 children, grown-up children, right? And if one comes and says, doctor, please don't tell my mother that she has cancer. Second one comes and says, doctor, please tell my mother she has cancer. What will you do? Which one are you going to listen to? Right? You must always ask the patient. I'm the doctor, you introduce yourself. You must, after the introduction and that initial part of it, you always ask the patient, what do you know about the illness? Patient has a right to know. Nobody else has a right to tell you. They have a right to tell you, but that doesn't mean that you have to do what they tell you, right? Nobody else but the patient. Unless your patient is very rare instances, like your patient is learning disabled or has some intellectual difficulty where they can't understand. In that case, of course, you may not, but those are very rare, right? In that case, the next caregiver or the next of kin will be able to receive the bad news. Okay, so just a few, anyway, you will learn as you go ahead, as you go along, right? This is a little bit like swimming. You can do a theory lesson on swimming, but the actual swimming happens when you jump into a pool, isn't it? No matter how many lessons you have, right? So unless you go and jump into the pool, you will not realize. But anything else that you want to ask me? I think we have a nice comprehensive package today. So you will be taken through various important aspects in your life as an intern. This is just a little bit of a recap of what you already know. If you don't have any questions, we can stop for today. You have, I think, a 5-minute break, perhaps before the next speaker. Anything you want to ask me, I'm more than happy to. So huge thanks to the ministry and the college for inviting me. And it's a pleasure being with the team once again. Thanks.
Thank you, madam. Next session will be conducted by Dr. Darshani Hettiarachchi. We will start at 10:20. welcome back. Our next session on mental illnesses in pediatric wards. It will be conducted by Dr. Darshani Hettiarachchi, consultant child and adolescent psychiatrist, teaching hospital Karapitiya. Over to you, madam.
Thank you so much. Good morning, everyone. Am I audible? Because I'm doing
Yes,
the
yes,
yeah.
yes, madam. Yes.
I'm just difficulty sharing my slides. Okay. I think you all can see my slides, right? But,
Yes.
but is it visual completely or
No, madam.
Sorry?
No, madam. Only the normal window we can see.
The window, right? Yeah. So I have to go to this slide sharing mode. That's something. Okay.
But madam, click on the from the beginning, that on the most left of the screen.
Left side.
From beginning.
From
That's
beginning.
yeah.
Fine. Okay, thank you. So now
Yeah.
you all can see it, right?
Yes, madam.
Yeah.
Yes.
Okay, so maybe I will stop the video because sometimes there can be connection problems if I continue the video. So during good morning everyone, and so during next 40 minutes, I will be discussing about the child psychiatric conditions in a pediatric ward. Like if you find it difficult to hear me, somebody can just interrupt me and inform me. Otherwise, I may just keep talking and you will not hear me. Right? So someone please interrupt me and let me know that if I become inaudible. And I am not very happy with the first, the name, the mental illnesses. I do not like that word when it comes to the children. The child psychiatric condition, so emotional and behavioral problems, what we see in a pediatric ward or in a pediatric setting. So before starting the conditions, I want you all to focus on the things which can come or which may you see in a pediatric setting. This pediatric setting may be either pediatric medical ward or pediatric surgical ward, or even in a medical ward, if that's we call children age from 0 to 18. So even when you are in a medical ward or a surgical ward, still you will say adolescent. So even if you think of doing surgery medicine, still you will have to listen to this lecture because still you may see children and adolescents in these wards. So what may be the common presentations which we see in pediatric wards? Like they will not come with diagnosis, right? And they will not come with child psychiatric conditions. They will come with medical or surgical problems. So what may be the possible presentations for you all to be alarmed whether this child is having a child psychiatric problem? One may be the speech delay. Other may be the hyperactivity or oppositional behaviors, or maybe very anxious child not obeying any medical procedure, or victimization of child abuse. So those, and also multiple somatic complaints. Sometimes the child may come to pediatric ward with multiple somatic problems, either headache, either abdominal pain, whatever. And pediatrician may have done all the investigations and everything may have come. I wonder whether you all can hear me because it says that my internet is poor. Okay, so likewise, different presentations. So that multiple somatic symptoms, it may be a presentation of depression. So those are the common presentations which you see. So I thought of give you a brief overview about these conditions which I have mentioned in this slide. The neurodevelopmental conditions like autism spectrum disorder, attention deficit hyperactivity disorder, and learning disorders, and emotional disorders like anxiety disorder, separation anxiety, specific phobias, generalized anxiety, OCD, selective mutism, and also depression. As I mentioned earlier, child abuse. So those are the common things which may you come across in a pediatric setting. What is autism? I think you all have already done pediatric appointments. You have come to child psychiatry clinic for maybe 2 weeks during your professorial appointment. So what is autism? Autism is a neurodevelopmental disorder which has two symptom categories. One is the persistent deficits in social communication and interaction, and restricted and repetitive interest and behaviors. So what are the features come under poor social communication? Children with poor social communication can have speech delay. Usually, a child should be able to speak 2 to 3 meaningful words by their first birth. And then they will be able to speak approximately 25 to 50 meaningful words by age 2. And by age 2, they will be able to put 2 words together. And by age 3, children should be able to speak approximately 250 to 500 words, and then they will be able to put 3 words together. This is a usual speech and language development in a child. But children with autism will have speech delay. Second feature is they will have speech regression. That is, parents might say at age 1 or 1.5 years, child spoke a couple of words, but now child can't speak those words even. So that is speech regression, which is a feature we see in autism. And the third feature of poor social communication in autism is sometimes these children can have their own language. We call it neologism. They have their own language, they speak in their own language, but none of the other people can understand. But the parents might say, he is using some words for these objects and we can understand, but it is not a functional language. Fourth feature is the echolalia. That is, children with autism tend to repeat the same thing what they hear. For example, if you ask from the child, ඔයාට බඩගිනිද? Child would say, ඔයාට බඩගිනිද? So that the child will repeat the same thing. That is echolalia. So these are the features of we see in children with autism having poor social communication. And so what are the features which come under poor social interaction? Children will have poor eye contact. That is, they will not look at your eyes when you try to get connected with them. Second feature is the poor joint attention. That is, they don't know that they need to focus on you and respond to you. A very simple example is usually if you pass a ball to a child, what would the child do? Child will pick it up and throw it back to you. That is joint attention. But if a child is having autism, these children do not know that they have to associate or respond to other people. And even if you throw a ball to the child, he will pick it up, but he will not throw it back to you and start trying to play with you. Usually, the child will try to avoid that interaction. And the next feature, which we can see in autistic children with poor social interaction, is the lack of emotional reciprocity. That is, they are unable to understand other people's emotions by looking at their faces, and vice versa. They also can't having difficulties in express their emotions through facial expression. For example, and also sharing their emotions. For example, usually children can understand their mother's feelings by looking at the mother. When they go out and try to do some naughty thing, and usually what the children do is they look at their mother's face. And if they see that the mother's face is not that desirable, then they will know that if I continue this behavior, then mother might react, or mother may scold at me when I go home. So that is what the child knows in normal child. And other things, that sharing their happiness and sorrow. Just imagine when a child gets a present or something from somebody, what would the child do? They will immediately bring that toy or present to the mother or the caregiver and try to share the happiness with them. Vice versa, when they have a fall or something, and if they get hurt, they will immediately come towards the caregiver or mother to get comfort. So that is the emotion sharing of their difficult emotions as well as happy emotions. In children with autism, we will not be able to see these features. Another thing is the difficulties in understanding social concepts and boundaries. That is, they don't know how to behave in a social situation. Second symptom component is the restricted and repetitive behavior, that they tend to collect same thing. They tend to do same thing again and again. They tend to be interested in only a same thing. For example, dinosaurs, building blocks or something, but they do not want to pay attention to other people. They appear as living in their own world, doing the same thing again and again. There are some early warning signs in autism spectrum disorder. I think these are important for you all, because you parents might not come and tell that my child is having a problem, because they are in a denial. Usually children with autism, they do not have dysmorphic features or anything for the parents to feel that their children are having a problem. They may only see the speech delay as a problem. So in a pediatric ward or pediatric ward setting, if you know these symptoms, or if you have this knowledge, you will be able to pick this up. So what are the red flag signs, or the early warning signs? Usually at 1 year, child should be, as I mentioned earlier, they should be having 2 to 3 meaningful words. So at age 1, if the child is not having cooing, reciprocal babbling, and also if the child is not having waving, pointing, and say tata bye at age 1, that is significant. Usually a child should be able to say tata bye and do pointing at age 1. Second is, if the child is not able to share the enjoyment, which I mentioned earlier, and no meaningful words at age 1.5 years, then it's significant. If the child doesn't have no spontaneous words and not having any interest with other children at age 2, again, it's an important sign. And at any age, if the child is not having good eye contact and no response when name is called and developmental regression, those are early warning signs. How do we assess? Usually, assessment and diagnosis of autism is a clinical diagnosis. So history, development, family comorbidities, risk factors, and then the examination, general examination, neurological. Because why do we need to do a neurological examination? There are some neurological syndromes where the autism can be coexist. So it's important to do neurological examination also. And specifically, you need to assess the speech and language, eye contact, social interactions, whether the child is having repetitive behaviors. Those are very important. And the most important thing that you need to know is that there is no specific investigation to diagnose autism. We do investigations to exclude other comorbidities. For example, if the child is having episodic behavioral changes and some features of ASD, we need to exclude whether the child is having epilepsy. In that circumstance, we may do EEG to exclude epilepsy, but autism, we don't have any investigation to diagnose autism. And what is the management? Again, the most important thing, to manage autism, we don't have a medication. It's mainly the behavioral and therapeutic management. So behavioral is what we call intensive behavioral interventions and occupational therapy, speech therapy, sensory therapy. But that is the most important thing. Just imagine when you're in a pediatric ward, like when after you start internship, even your relatives or your known people, neighbors might come and now they will start thinking that you know, like now they will identify you as a doctor and will come with various problems. Just imagine a neighborhood child is diagnosed with autism spectrum disorder, and they will come to you with a problem and say, doctor, now my child was given this diagnosis and they didn't give me any medication. Do you think this child needs medication? Or those kind of things can be asked. Then if you know this information, no, autism is a neurodevelopmental disorder. We don't have any medication to improve the symptoms. We only have behavioral and other therapeutic management. So if you know this information, you can confidently tell other people that this is the proper management. And other thing is, people might ask from you when it comes to autism, සනීප වෙනවද මේක හොඳ වෙනවද? So this is a neurodevelopmental disorder. We do not talk about cure. We only talk about symptom improvement and functional level improvement. So that is how would they present. Now I think you will have some understanding. If a child is having a speech problem, and if the child is not responding to the name, not having eye contact, no joint attention in the pediatric ward, it's very important for you to pick these symptoms. You should ask about the history and the development, and then you should inform your seniors to do relevant reference. Now, hyperactivity. You will see this very commonly in the pediatric ward, the hyperactive children. So to diagnose hyperactivity, those are the symptoms, either inattention component or hyperactivity, impulsivity. So what are the features which come under inattention? Careless mistakes at schoolwork, difficulty in maintaining attention, doesn't seem to listen when spoke, doesn't follow through instructions, difficulty in organizing tasks, avoid or dislike to engage in tasks which need sustained attention, because they may be able to do things for a shorter period, but they can't maintain attention for a longer period. For example, jigsaw puzzles, making building blocks, they are not good at those things, and they will try to avoid these things and lose things frequently, easily distracted, forgetful. What are the features of hyperactivity? Impulsivity, often fidgeting, often leave seats in situations with remaining seated is affected, and inappropriate running, climbing, unable to play or engage in leisure activities, often on the go, acting as if they're driven by a motor. They talk excessively, blurts out an answer before the question is completed, difficulty in waiting for turn. So those are the features. So what will you do? What will you see in the pediatric ward? You will see hyperactive children. Like, they will run here and there and not stay on one place. Very difficult to engage them for a therapeutic procedure. They will pull, they will pull the things, the cannulas. They will not obey the commands. They will not be able to stay one place. Those are the features. And sometimes children with hyperactivity will present with repeated injuries and repeated admission. So if you see a child coming with repeated admission, with repeated injuries, this should come to your mind whether this child is having hyperactivity. To diagnose hyperactivity, these symptoms have to be there for more than 6 months, and it shouldn't be consistent with developmental age, and symptoms present prior to age 12. And the most important thing is these symptoms should be there in 2 or more settings, either at home and school or home and Sunday school, wherever. Anyway, the symptoms have to be there for more than in 2 or more situations. And also, in addition to the symptoms, there should be some kind of functional impairment secondary to these symptoms. And symptoms are not due to another mental health disorder. Here, it's different from ASD. We have medications. I think you know it. Stimulants and non-stimulants, and also behavioral management. Anxiety disorder. This is also a common thing which we might encounter in pediatric ward settings. Separation anxiety, specific phobias, social anxiety, generalized anxiety, OCD, and selective mutism. So what are the features of an anxiety disorder? Excessive, unmanageable anxiety comes unexpectedly, causes significant distress and functional impairment. And other thing is, anxiety is out of proportion to the impact of the event. For example, child may be scared of butterfly, but the child might think that he will die of seeing the butterfly. Likewise, this anxiety is out of proportion to the impact of the event. And anticipatory anxiety, that is, children will get scared, even think about the object. And avoidance of anxiety. So usually what might you see in the pediatric ward is either blood phobia, injection phobia. Those are the common things you may see in pediatric wards. Again, separation anxiety. You may see in the pediatric ward where child have to get admitted to the pediatric ward, where the most attached person is unable to stay with the child in the pediatric ward. For example, if the child is attached to the mother and this child gets admitted to the hospital, but if the mother is having a younger child and mother can't come to the hospital, so then the child will stay in the hospital with the father, there the child will show features of separation anxiety because the child's most attached person is mother. Developmentally appropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached. And they will show excessive distress, excessive worry of separation, refuse to go out, sleep problems, nightmares, unexplained physical symptoms. But to give the diagnosis of separation anxiety disorder, these symptoms have to be there for at least 4 weeks. So you will not be able to give that diagnosis in the pediatric ward because usually you are not going to keep a child in the pediatric ward for 4 weeks. But you will see separation anxiety. And if you have a child with separation anxiety in a ward, you might find it difficult to follow the medical therapeutic procedures with the child. Again, the management, reassurance, anxiety management, behavioral management, supported the family, and last resource is the anxiety. But usually we do not encourage medications for separation anxiety disorder. And this is another important thing, that is selective mutism. In selective mutism, usually children have their normal speech and language developed. But due to anxiety, they will not speak in specific social situations where they have to speak and anxiety provoking. For example, if a child is having selective mutism and get admitted to the pediatric ward, child will be so anxious to talk. Then, as the pediatric team, you might find it difficult to get the information from the child because child will not even speak a single word. Sometimes, parents say so many different stories and you will need to talk to the child directly. Imagine if the child is having selective mutism and he or she doesn't speak a single word, but it will be very difficult for your management. So management, again, relaxation exercises, behavioral management. Final option is the medications. And specific phobias, as I mentioned earlier, the marked fear or anxiety about special objects, situations like flying, heights, animals, injections, blood, then the object or situation always provoke anxiety. And they try to avoid the situation. And again, they can have anticipatory anxiety, and symptoms have to be there for more than 6 months, and there should be significant functional impairment due to this. For example, if the child is having injection phobia and due to that, if the pediatric team is unable to give the child the relevant injection, then there is significant functional impairment. Then we need to intervene this phobia. Management, again, behavioral and medication. Social anxiety, usually we see in older children, that is why I say adolescents and young adults. So if you do your intern in a medical or surgical ward, there you might see this population who can come with social anxiety, where the main feature is marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny of others, having conversation, eating, drinking, giving a speech. There, the main body is the fear of negative evaluation by others. And social situations always provoke anxiety, and they try their best to avoid social situations. And again, the symptoms have to be there for more than 6 months, and there should be significant functional impairment. Management, again, behavioral and psychological. In general anxiety, they are always anxious. What we usually say, so you can see children with excessive anxiety even in a pediatric ward. The biggest problem is, again, it will affect the therapeutic procedures. The child will not take medications, child will not give history, child will be anxious, worried. So those are the child will be worried to move from one ward to another, one cubicle to another. So imagine if a child is always crying, anxious, then it will be very difficult for you all to do your proper pediatric management. And OCD, here, I think due to the limited time factor, I'm not going to describe about the OCD in detail. I believe believe you all have some understanding about OCD, where children get repetitive, intrusive, senseless thoughts, and they try, which are distressing, and they try their best to avoid it. The common presentations, what you would see is the washing, checking, counting, orderliness, those kind of things. And I think the most important area that I need to focus here is the depressive disorder, because we see many children who are having depressive symptoms will not present to child psychiatric clinics directly. They may present to the pediatric wards. The most common presentation is the unexplained somatic symptoms. So if you see a child with unexplained, physically unexplained somatic symptoms, this differential diagnosis should come to your mind, whether this child is having a depressive disorder. So what are the main features of depressive disorder? Low mood, withdrawal behavior, irritability, anger, or they get angry very easily. Lack of energy, lack of interest and enjoyment, loss of interest in extracurricular work, poor self-care, low self-esteem, poor attention concentration, poor sleep or excessive sleep, and complain of headache, stomach ache. And adolescents, sometimes they tend to use alcohol and other substances as a way of self-medication. Sometimes they can have suicidal ideas. And if these symptoms persist for more than 2 weeks, then we need to consider. And if there's any functional impairment due to that, then we need to consider it as significant. So what I want to highlight is that when you see a child in the pediatric ward who is having unexplained somatic symptoms and getting admitted repeatedly with somatic symptoms, you need to consider, you have to have this differential diagnosis in your mind, whether this is depression. My final slide is the child abuse, because this is something which we see very commonly, and in most of the cases, actually, the pediatric team pick this problem, because when the victims of child abuse, they are very helpless, and most of the time they would not, especially when the perpetrator is known and the perpetrator is living with them, they are scared and they are helpless to disclose the information. There, most of the time, this victimization of child abuse is an incidental finding in a pediatric ward. So when we talk about the child abuse, there are 4 types. One is the physical abuse, sexual abuse, emotional abuse, and neglect. So what are the physical? What is physical abuse? That is the non-accidental injuries like punching, beating, kicking, biting. Those are the non-accidental physical injuries. And how do you detect? What are the features? Usually the child will not say that this person assaulted me, but there are some features for you to be allowed. For example, the child may be having multiple injuries and multiple stages of healing, and also the injuries may be on accessible site, and also the history may be inconsistent. The child says something, mother says something, father may say something else. So inconsistent history. And other thing is delayed seeking help. Imagine if a child is having a fracture and the parents have not come to seek help for 2 to 3 weeks. So that's something really significant. So delayed presentation. And also cigarette burns, other burn injuries are also you have to be suspicious when you see these things. Those are the features of physical abuse. Now let's move on to the sexual abuse. So there are 2 types of sexual abuse. One is the touch type. In touch type, there should be some kind of sexual contact. In non-touch type, actually there's no any sexual contact, but exposure. Like if the adult has shown his genitalia to the child, or the adult has tried to see the child's genitalia or showing child pornography, those things come under non-touch type. Usually, we might not be able to pick this non-touch type where victimization of child sexual abuse in the pediatric ward. However, there is one feature, if a child is expressing some very advanced sexual information or sexual knowledge which is too advanced for his age. For example, if a 7-year-old child is talking about sexual acts, videos, those things, then you should be allowed. How come this boy got to know this? So if the child is having very advanced sexual knowledge, and if the child is talking about sexual things freely, then you should be allowed. How did this child got exposed? That is for non-touch type. So what are the features we have to be allowed when we see these features? One is the obviously damage trauma to the vagina. Second thing is the foreign body in a vagina. And third one, what may be the reason for the child to have foreign bodies in the vagina? One reason may be if the child has already exposed to these sexual contacts, and if the child got some stimulation, this can be a learned behavior. Child may try to insert things into the genitalia to get stimulation. That is one thing. Other may be sometimes the perpetrators may insert things there to conceal the evidence. So those are the reasons for insert foreign bodies in vagina, and also sexualized behaviors in children. Another thing is the PR bleeding. Chronic constipation, because with the PR anal sex, especially in boys, after having anal sex, they may get tears, and with that painful defecation, they may have chronic constipation. Also, the chronic constipation, PR bleeding, or if you see these things, you should be alarmed. And especially if you see a child coming from an institution or religious institution, it's very important. Whenever you see a child with PR bleeding, yes, you need to look for any evidence of victimization of sexual abuse. And emotional abuse, I think you might see it like criticism, threats, rejection, withholding love. So what are the features of neglect? There, the parents or the guardians are unable to fail to meet the child's needs, physical needs, providing food, and then the educational needs, unable to send the child to school, giving adequate education, emotional needs, that is love, affection, and medical needs, that is seeking medical help on demands. So those are the features. So when you suspect a child with victimization, you should immediately inform your seniors. Then the procedure would be to inform the police, DMO, child psychiatrist, having a case conference. All these things will be done later. But whenever you get any alarming sign, what you have to do, you get more information and then you inform the seniors. At intern level, that is what we expect from you. So that comes to the end of my presentation. So I have 2-3 minutes. I think, yeah, I have 3 minutes. If you have any question, maybe you can put the question to the chat box, but I can't see any messages or any question. But still, there are 3 minutes. If anyone has any question, you all are free to ask or send a message to the chat box. No questions? Were you all there? I'm not very sure about that, you know. I also have been a pre-intern. So I wonder whether actually you all have logged in or whether just you all are pretending that you all have logged in. Anyway, if there are no questions, maybe I can conclude my presentation. Thank you, everyone. And I wish you all the best for your internship and your future career. Thank you.
Right. That was Dr. Darshini Hettiarachchi, consultant child adolescent psychiatrist at Teaching Hospital Karapiti on mental illness and pediatric ward. If you all have any questions, we can take 1 or 2 minutes to answer them. You can unmute or you can use chat box.
Okay, then I can leave, right? If there's no any question.
Yes, madam. Yes, thank you very much. Okay. Right. Next up is mental illness, alcohol and substance misuse disorders. The topic done by Dr. Amila Isuru, senior lecturer and the consultant psychiatrist at University of Rajarata. So he's locked in. So over to you, sir.
Good morning, everyone.
I'm sorry, sir.
Can you hear me?
Yes, yes, we can see slides as well. So can we move 1 or 2 slides?
Yeah. Can you see that?
Sir. You can start. Yes, sir.
Okay, right. Okay. Good morning, everyone. And so I take this opportunity to congratulate on successfully completing exam, and you all are about to take up the most precious, most valuable role in your life, being a doctor. So we all are really proud of you, and congratulations for that. And so for when you become a doctor, and so it is, we are kind of, I'm thankful to Ministry of Health organizing this, that you will be getting some important glimpse of knowledge and skills for you to work as a good doctor, right? So this is alcohol and substance misuse, topic I have been covering, and I'm sure you have been learning this over your faculty days. So many lectures, you might have seen lots of patients and helping out them in many ways. And so I'll take you through some important steps that you need as an intern house officer, right? And the first thing is, why are we so bothered? Why are we talking about substances everywhere? And what's the role of doctors? And so if I take you through a few things, the most of the patients you encounter, and patients with malignancies, ischemic heart disease, strokes, and psychiatric illnesses, you'll see there are lots of patients with psychotic illnesses and cognitive impairment present with people who use cannabis. Now there are a lot of patients we are seeing. And in general, there's substance misuse, alcohol, tobacco, and all other substance misuse cause full range of psychiatric illnesses, right? And sexual dysfunction. And there are so many physical and psychological illnesses caused by the substances, tobacco, alcohol, and other psychoactive substances. So it is really important for us to prevent that, right? So for example, in alcoholic patients, when they get cirrhosis, there are very few things we can do, right? Improve the quality of life. But if you found that patient kind of 10 years before he developed cirrhosis, so 5 years before, if you have intervened at that point, you could have saved the person and saved their family as well, right? Help their family as well. So there are so many things, so many illnesses can be prevented if you address substance misuse issue properly. And other thing is, so as a country, we are spending enormous amount of money on healthcare system to deal with patients experiencing physical and psychological illnesses due to psychoactive substances, right? That is another major problem. And so other thing is lots of premature deaths. And sometimes it was reported that around 40,000 people are dying prematurely in Sri Lanka because of substances. Tobacco is accounting for sometimes 22 deaths per year in some years, right? So this is something very important, right? Okay. And so what is the role of intern medical officer? So we understand that you are really busy in medical wards, you get hardly any time to sleep and or eat and things like that. And so you continuously working, and so you are attending to so many emergency situations, and you are looking after sometimes on the ward 50, 60 patients. And so while you are doing this job, what is the role of intern medical officer, right? The first thing is that to identify and manage medical emergencies related to substance use disorders, right? So can you please tell me what kind of medical emergencies would you encounter related to substance misuse? Can someone please tell me, or can someone please, if you are too shy, you can type it in chat box. Yeah, withdrawal symptoms, withdrawal symptoms per se it's not a medical emergency. Yeah, delirium tremens is a medical emergency. That is very good. Yeah, so you will encounter delirium tremens. Anything else? Any other? Yeah, sometimes acute Wernicke-Korsakoff, very good. Yeah, very good. And sometimes acute psychotic episodes can be, it is quite challenging, and substance-induced psychosis you will see on a busy medical ward. Sometimes it needs lots of resources to handle that kind of patients, I agree. And Wernicke-Korsakoff syndrome is another one. Yeah, and anyone else? Hypoglycemia, very good. Yeah. So I'm happy with most of your answers. So I'll also answer, give you a few answers, right? So what do you think about opioid toxicity? Right, it's fatal, right? So it's a medical emergency. Most of the time in as acute ward, in a casualty ward, patients with opioid toxicity, they are very calm, right? So they don't cause any troubles, right? They have labored breathing, and their pupils are constricted, and so they are drowsy and all, right? If you do not attend properly, they will die of respiratory failure or something like that, right? So that is something very important. Opioid toxicity also having high index of suspicion. And the alcohol withdrawal seizures again, right? So they are also kind of comes as medical emergency. And so we'll say now, so what, yeah, so we need to deal with medical emergencies related to substances. That's a definite role of intern medical officer, right? Okay. And do we have a role in prevention? What do you think? As an intern medical officer, can we play a role in prevention of substance misuse? Yeah. Tell me about what do you think? Okay. So this is not a difficult question to answer, right? So I would like to see your responses. Yes or no? Okay. Right. I would like to see as much as responses. What do you think? So I'm not judging you. I don't know most of you, right? What do you think? Do you have a responsibility? Okay, yes. Anyone else? Yes, yeah. Thank you for that. Yeah, we do have a role in the prevention, because, for example, a person comes to you with a chronic cough, right? So with his smoking tobacco, right? And if you can talk about, and for a few minutes, right, talk about and the possibility of stopping that, right? Bolster his self-efficacy, telling him that he can do that. And you can ask few things about what are the problems of smoking, and the patient will give few things like lung cancer and things like that. Then you can give them a more kind of a more information about the substance misuse, the consequences. Apart from lung cancer, you can say ischemic heart disease, stroke, sexual dysfunction, and things like that. You can broaden their knowledge as well, and then you can offer adequate you can guide them to where to get the support and things like that, right? So just a few minutes, right? You can save a life. Okay. Okay. Yes, we do have a role in the prevention. Now I'm doing this as a kind of an interactive session. I want you to answer, or you can type your answers in the chat box, right? A 55-year-old farmer admitted to surgical casualty ward following a road traffic accident. He became confused and started seeing snakes on the floor of the ward, right? Now you are the intern house officer. How do you approach this situation? Now we are talking about few practical things, right? Tell me, how do you approach this situation? Okay, delirium tremens. Anyone else? In alcoholic hallucinosis, you have hallucinations in clear consciousness. They are not confused. I like this answer, impact of head injury. Yeah. Hypoglycemia, any cause which can cause delirium, anything which can cause delirium is a possibility. And delirium tremens is high in the list, but anything, the delirium can cause this kind of presentation as well. So we need to look at the possibility of delirium tremens, and at the same time, so if it is delirium tremens, how we do manage is you might start chlordiazepam oxide, right, diazepam, and very small dose of antipsychotic if patient is very disturbed, right? So if it is hypoglycemia, just giving that medication wouldn't help. If you do not detect hypoglycemia, patient will experience permanent brain damage following hypoglycemia, or patient might die. If it is hyponatremia, then it will be a problem, right? As you said, if it is intracranial hemorrhage or something like that, you might need to kind of attend promptly. Okay. So this kind of presentations can you will encounter, but most important thing is you need to have some information about substance history. This is where substance history is very important, right? If now patient is confused, you can't take substance history, right? But at the time of admission, if you took substance history, right? So if you take in 3/4 bottle of Arak per day, now you are expecting withdrawal symptoms, right? You are expecting severe withdrawal. Now, if you start at chlordiazepam oxide, what will happen is then patient will not experience delirium tremor, right? It will save patient's life and your time, right? Okay. Now we look at the second case. A 42-year-old school teacher admitted to medical ward with the symptoms of gastroesophageal reflux disease. He developed a seizure on day 2 of the admission, right? Kind of a similar scenario, okay? So this teacher must have been taking alcohol. If you detect that, right? If you detect that at the time of admission, you could have done something about it. You could have done medical assisted withdrawal, okay? And as you said, at the same time, it's not only the alcohol withdrawal seizures. You need to think about the other possibilities, because seizures can cause so many due to so many other causes. Right. Now tell me answer to this question. A 45-year-old carpenter who is regular use of alcohol presented to medical ward with faintishness. He was given 5% dextrose IV infusion. Nurses informed you on the same day night that this patient is confused and ataxic. What would you do? Tell me your answers, or you can post in chat box. Anyone else? Yeah. Yeah, most of you got this correct, right? And this is acute thiamine deficiency. You know, the patients with alcohol dependence are at a risk of developing thiamine deficiency. When there is acute thiamine deficiency, it can cause Wernicke's encephalopathy, which is a medical emergency. What will happen if you do not treat Wernicke's encephalopathy? It will go into Wernicke's Korsakoff psychosis, because Korsakoff psychosis has anterogate and retrograde amnesia, and there's a quite disabling condition, and most of them do not recover if we go into Korsakoff psychosis. So it is really important to look at the problem very early, right? And so it's really important to look at the other features of Wernicke's encephalopathy. Most of the features of Wernicke's encephalopathy, like confusion and peripheral neuropathy, ophthalmoplegia, ataxia, there are so many, most of these symptoms overlap with the withdrawal symptoms of alcohol and side effects of benzodiazepine, right? So it is, sometimes it's really difficult to detect the features of Wernicke's encephalopathy, and you might miss, and patient can go into permanent disability, right? So in that kind of situations, what can we do? We will prophylactically start thiamine infusion after the admission. If patient has been taking alcohol considerable amount, if you are suspecting Wernicke's encephalopathy, so you can prophylactically use IV thiamine to prevent this kind of presentation and to prevent the diagnosis being missed, right? So this is something very important. Yeah. Now tell me, this is one of the very important slide in this presentation. And so how you could have prevented these medical emergencies, right? This is something very important, right? This is the thing you need to learn from this talk. This is something you can take home to improve your practice as an intern medical officer, and after that, right? So whenever you encounter a patient, don't forget to take substance history, right? Afterwards, when you feel it is necessary, you may not be able to get the substance history, right? So at the time of admission, spend few minutes to take a detailed substance history, right? And it's really important to screen for withdrawal symptoms as well, right? If you detect withdrawal symptoms earlier, you can treat them to prevent, for example, with alcohol, you can prevent serious complications like withdrawal seizures and delirium tremens, right? And other important thing is you can detoxify them under medical supervision, okay? And prophylactic therapy. So these are the few things you can do to prevent, right? To prevent medical emergencies. Yeah. One is asking, shouldn't we inform senior or decide to infuse thiamine on our own. Yeah. So if you are very confident, you can start, and there is no harm. We are anyway prophylactically starting thiamine, but it's always, you must, when you are handling with a medical emergency, it's always you must inform your seniors, right? And so this is another important skill you need to develop when you are doing your interns, right? Always try and work with the team, right? And if you're handling a medical emergency, you do things which cannot wait, right? If, for example, if patient is hypoglycemic and you correct the hypoglycemia, right? But it's always important to have a very good discussion with your seniors because they have more experience. They will give you more important information to save patient's life. And when you handle a patient, you will get a good feedback from your seniors, which will help you to kind of improve yourself. That is helpful for your personal growth as well. Okay, that is again something very important. Okay, right. So these things, screening for substances is very important. Right. Now, a 22-year-old street vendor brought to emergency treatment unit. He was found unconscious on the road. On examination, you found that labored breathing and constricted pupils. What are the possibilities? What do you think? Yeah, almost all of you got it correct. Yeah, thank you. And I'm happy with this group, right? So this is something very important. You might miss this in a busy ward. And so this is suggestive of opioid overdose. Very good. And as Mohammed said, we need to think about the pontine hemorrhage as well, because that can also have a same presentation, right? So this is something very important. You can check the urine and blood for the opioid as well, right? So you need to resuscitate the patient early, and naltrexone or something you need to give, right? So this is again another medical emergency when you are when we think about the substances. Right. Now, so now we are come to a kind of a different topic. For example, about the prevention aspect of role of prevention of an intern medical officer or a doctor, right? So we can screening for psychoactive substance use. It's something very important. As we discussed so far, it is really important to screen for substance use during the history and examination, right? So if you find that patient is taking substances, if you pick a case, that would be really helpful in the management or prevent future consequences, right? If they're taking substances on and off, you can prevent them becoming dependent, right? You can save individuals' life. And for example, if someone is taking alcohol, right, and he's spending most of his income on alcohol or any other substances, right? And if he's quarreling at home, fighting with wife, domestic violence and things like that, right? Substance misuse ruin his life, his financial status. It will ruin his children's beautiful childhood, right? It will ruin the quality of life of his wife, right? So whole family get affected, okay? So that is something very important. And if you identify and address substance issue, if you bring down the substance use in people in the community, it will bring down the crime rates as well, right? So you can read around the topic, how to help a person who is misusing substance psychologically, right? You can bring a huge change in patients and their family and the community at large. You don't have to spend hours and hours, right? You can spend 5 minutes to counseling. These are the few important communication skills that you need to develop, right? So express empathy. So what will happen when patients with alcohol brought you to the ward with alcohol withdrawal fit? People are really angry. This guy is taking alcohol. Now we have to spend time on him, right? The whole ward is upset, right? So people with alcohol problem, alcohol and other drug use problems, they have enough and more problems because community label them and they are discriminated and their physical health is not that great, psychological health is not that great, and they are not having a proper affection from their family and friends as well, right? So they are going through a tough time. So express sympathy and try and understand them, right? Don't label and discriminate them, right? Try to build up an initial rapport with the patient, right? And so, for example, if a patient comes following road traffic accident and patient tells you that, okay, doctor, I take alcohol only on the weekends. So I met with the extended my life under influence of alcohol. I won't do this again. Alcohol is not a problem to me, right? And so it is not advisable to argue with them, right? Always avoid argument, right? Instead, you can create a discrepancy. Okay, then you will see that you can say that, okay, I can see that. So you are taking alcohol only over the weekend, but you give money to your family and you are taking care of your family and children as well. But what do you think about spending your time weekends away from home with friends having alcohol? Do you think that situation make your family happy? Do you think you can use that time more productively, right? Do you think you can save that money? How much money you spend on alcohol? And you can ask about his salary and just tell that quite a sizable amount of money he spent on alcohol and things like that. So you don't argue, but you develop a discrepancy of what is belief and the reality, right? And the support the self-efficacy. So any substances, it is not a very difficult thing to come off substances, right? And so always you need to encourage the self-efficacy, support the self-efficacy, right? Sometimes, most of the time, patient thinks that if I am dependent on alcohol, I can't stop it. If I'm smoking, I can't stop it. If I'm taking heroin, I can't stop it, which is not true, right? Anyone can stop at any time. The research evidence says that more than 70% of people who stop taking psychoactive substances do they on their own without any professional help, right? So this is something very important to bolster their self-efficacy. So these are few communication skills when you need it when you are talking to your patients with substance misuse problems, right? So when we talk about the role of prevention, and so first, as we discuss screening, less than 20-second intervention in prevention, right? So this is something really important. If you spend less than 20-second intervention, that you just ask about the substances, patient's viewpoint, you give your viewpoint, you convince them the possibility of stopping the substances. This kind of brief conversations are very effective, right? So they have shown that 25% of people completely stop substance use after this kind of even less than 20-second interventions, right? If you have more time, you can do more interventions like brief intervention and motivational interviewing, right? So motivational interview, you might have seen this, you might have learned this in your undergraduate time. There are a few phases of change pre-contemplation, contemplation, determination, action, maintenance, and recurrence phase, right? So what you need to understand is people are in different phases of change, stages of change, right? And sometimes people are really pre-contemplating and they very much resist the information you are giving. Then rather than completely blocking them off, you can say that, okay, think about again. And if you think you need support, you can come back. If you think you need support, this is the way you get the help, right? And the important thing is, for example, you have a patient with chronic liver disease due to alcohol misuse, and you treat the patient and send him off. After 3 months, patient again comes to your clinic after taking alcohol, right? So this relapse prevention, this is something very important. Since we are running out of time, I'm just not taking your responses, I'm just giving the answer. And so whenever they come, so this is the natural process of healing, right? Yeah, someone has answered. Yeah, very good. Show empathy. Yeah. Yeah, absolutely. Bandar, yeah. Good. And when they come, right? So what we usually do is kind of a we blackguard them, right? So that is not the case. We really appreciate them coming back to seeking help, right? And we talk about how long you have been off alcohol. For example, if they say 5 months, then you bolster their self-efficacy, saying that, okay, you have stopped taking alcohol for 5 months. That means you can do. Then you explore as to why he restart taking alcohol and take that opportunity to prevent him taking alcohol again, right? For example, patient had an argument with his wife and became distressed and start taking alcohol, right? Then you can basically talk to him and probably refer to a family counselor or couple counseling or something like that. And so help him to kind of find a more productive way of handling his stress, right? That is something very important, right? For example, in a party, a friend given him alcohol because he's not having quality of resisting that, right? So you teach them a bit of assertiveness training, how to say no, right? To alcohol and things like that. And so in that kind of situation, if patient comes back to you with a relapse, right, you need to acknowledge and appreciate him coming, right, and explore and understand what kind of situation push him to take alcohol again, and take that opportunity to, as a learning experience, to prevent him taking alcohol in future, right? Okay. Right. So when we talk with the patients, and different patients come in, are in different stages of change, right? So some people does not want to stop, some people want to stop, some people comes in relapses, right? So you need to have a different approaches, right? Patients' socioeconomic background may be different, right? IQ might be different, right? Cultural belief might be different. The problems they encounter might be different. So understand about their context and do some patient-centered and patient-centered support. Okay, right. Okay, that brings us to the end of the presentation. If you have any questions, I'm happy to answer.
Right. Thank you, sir. But still, we have about 5 minutes left. So if anyone wants to ask some questions, you can use this time and ask.
I can wait for 5 minutes if you have questions, right?
Yes, sir. We are giving a break at 11:40, so we have another 5 minutes time.
Okay, right. Someone asking taking consent from patients. What do you mean? It's not clear. Taking consent for what? To clarify, I'll answer. Yeah, very interesting question. Waiting for ECT without a bystander, right? So even though this is off the topic, and yeah, this is interesting question. And if you want to give ECT, the bystander consent is not valid for electroconvulsive therapy, right? It is always a good practice to discuss with the bystander and the family members and inform about the electroconvulsive therapy. It's a clinician, it's a psychiatrist's decision, consultant's decision to give ECT to save the life. This is life-saving treatment, right? If patient's life is at risk, for example, high risk of suicide, self-negligence or something like that, catatonia or something like that, you need to decide on your own on behalf of your patients. The family consent is not valid, but it is always a good practice to inform the family about the electroconvulsive therapy benefits and side effects and make them aware of it, right? So not having a bystander is not a problem. If you think it is needed, you can give. Yeah, absolutely. Very good. So this is another major problem. And patients with alcohol problems, they commonly experience the hypoglycemic episodes because of the liver problems and poor dietary intake. And always, if there is a history of alcohol, significant use, always give thiamine before dextrose. Otherwise, the existing stores of thiamine will be depleted. Patient experience acute thiamine deficiency, which will lead to annuncase encephalopathy. Yes, Samir, this is a very important question, actually. So patients with alcohol misuse, long-term alcohol use at a higher risk of developing thiamine deficiency because the thiamine converted to thiamine pyrophosphate in the liver. When the liver is not properly functioning, that conversion is not happening, and the gut edema prevent thiamine absorption, and they're anyway taking less amount of food, and the liver stores are adequate only for 24 hours because of all of the above, they are running a high risk of developing thiamine deficiency. It's always good to give thiamine prophylactically, and definitely if you are planning to give dextrose, give thiamine before that, which is life-saving. Thank you.
Right. Thank you very much, sir, for that comprehensive lecture. So
you are very welcome, and I really enjoy teaching you guys. You are very, very interactive and all. Thank you very much. I wish you all the very best.
thank you very much, sir. That was Dr. Amila Visuru, consultant psychiatrist and senior lecturer at the University of Rajarata. So thank you, sir, once again. So we're going to go for a tea break from 11:40 to 12:15. So 12:15, come back. Thank you. So 12:15, we are having the lecture by Dr. Chamara Vijayasinghe, senior lecturer and consultant psychiatrist at University of Ragama on psychiatric emergency in general hospital settings and managing aggressive patients. So that's the next topic. Okay, thank you. So welcome back after the tea breaks. So next up is another interesting topic by Dr. Chamana Vijayasinghe, senior lecturer and a consultant psychiatrist at University of Ragama, on the topic of psychiatric emergencies in a general hospital settings and managing an aggressive patient. So I think this has already logged in, so we can slowly start the session. Over to you, sir. So can you hear?
Yeah, thanks, Roshan. Nice to see you after a while.
Yes, true. Same here.
Okay, y'all can hear me and see the screen?
Yes. Can we move few slides and see this movie?
Yeah.
Yeah. Perfect. Yes.
Okay, thank you. Okay. So thanks for organizing this from the Ministry of Health, Roshan, and welcome all the interns. Congratulations. You all have come a long way. And now you all are doctors working on the wards. So it's a great achievement, and I wish you all the best. Trust me, no matter what people say about internship being difficult, nothing is as difficult as A-levels and final MBBS, or even the scholarship at the age of 10. So many of you all have done all these three things. So this will be easier and actually much more fun than you think. But before doing it, everybody is very anxious. So to reduce the anxiety, we are just giving you some knowledge, but everybody goes through this stage, and you all will too. So to discuss psychiatric emergencies, which you will see in your wards, whether it's medical, surgical, GynObs or PED, we'll discuss 5 patients who have come to medical and surgical wards at Ragama. And these patients were initially seen by interns. So this is the sort of actual scenario of what you all will see. And how I would like you all to do it is, just send in, I'll ask some questions just to keep you all awake. It's difficult to do a psychiatry lecture immediately after lunch. To send in your answers on the chat. So you all are also awake, and I know you all are engaged in this. So it's a thinking process. You have to do it quickly because it's an emergency. It won't take too much time. No marks are given. Nobody will be scolded. I only scold the Ragama students, but not after they pass out. Okay, right. So this is your first patient. You're the intern in the surgical ward. There is a laborer brought by co-workers and admitted to your ward. The nurses inform you that the new patient is talking to himself and laughing. Like, you all have to realize that in many hospitals you all work, even in Ragama, which has a psychiatry unit, this patient is first admitted to a surgical ward, right? So psychiatry varai, then medicine surgery thamai kiyala ehema bෑ. Psychiatry is always there. When you ask him what happened, the patient says that all the people are jealous of him, but God will punish them as he is the son of God. No collateral history is available when you come to clerk the patient. His vital signs are normal other than a tachycardia of 100 beats per minute. Pupils are equal and reactive to light, and no head injury appears to have occurred. You are in the process of writing basic investigations when you suddenly see him assault an attendant. Right? Now, this is an emergency. Your staff is getting assaulted. You're the intern in the ward, the consultant surgeon, SR, SHO, everybody is in theater. What do you do? Right? So these are the options you have to do. What I want you to do is, given it's an emergency, quickly mention the order of what you all will do. So your answer will be E, C, I, K, B, something like that, depending on what you all feel is first. Okay, I'll give you all 2 minutes. Send your answer quickly. you all are sending answers. Your answers are right. You all don't have to send it to me directly. No need to be shy. Put it on the main group. Okay, good. So many of you all send the answers, but please put it on the main chat so it's easier for me as well. So this is the order in which you will do this. Okay, all answers are right. It's like a single best response, but you need to think quickly and do this. So you call other staff and go in. You don't try to verbally de-escalate by yourself. The patient is manic. He can be aggressive. He won't realize that you're the doctor when you're psychotic. He thinks he's the son of God. So what you need to do is immediately go in with other people. If it happens in Ragama, I will go in with male nurses, male attendants, male medical students, and try to settle the situation. After you go there, you try to speak to him. He might have been hitting people, but you have a group of people around you. You're the doctor. You can speak to him and ask, why is this happening? Ask a nurse to call your SHO or registrar immediately and call security. Those happen as you go in. Okay. Next, you have to give something. If he's not settling verbally, it's unlikely that this person with psychosis is going to settle verbally. Give oral haloperidol. I'll talk about the doses later. Administer IM haloperidol if he's not settling or if he's refusing medication. Then you make a psychiatry referral. You don't wait to make a psychiatry referral like it's going to be a disaster, right? And psychiatry referral like you will realize won't happen quickly. To cover yourself, this is a serious incident, you need to write to the director and the police post. Tying the patient is a last resort. You don't do it, but sometimes when there's nothing to do to keep the patient safe and the others safe, you might do it temporarily only. You attend to other matters after sorting this. That is important. So what are the lessons you learn here? First of all, look after yourself. You know, you all only know how much you study to get here. After getting here on the first week, you can't get assaulted, right? So always look after yourself. That is not being selfish. That is being practical and having common sense, right? If you get assaulted, you don't have anybody into the shift, that doesn't help anybody. So you look after yourself while looking after the patient. Seek help, right? Sometimes when you become interns, for some people, you need the right level of confidence. You need to be confident. You don't have to be like a medical student and or the ward doctor. So you have to be confident, but don't be overconfident also. You have a consultant, no? Right? So when you go there, you will realize that life has changed now. From being a medical student getting scolded, you're like, what to in a podi doctor, podi mahatyari, podi nonari, and people respect you and people stand when you go in. So sometimes you sort of lose sight of who you are. It is nice to be respected and you deserve respect, but remember, the psychotic patient is not going to respect you because he is psychotic. So if you think you can go in there and tell him to sit or tell him to take medicine, you're wrong, right? So don't lose yourself in this process, but by all means, be confident, be firm, and people will respect you. You can treat emergencies. You inform, you have made the call. You don't wait. The SHO might be assisting a surgery. He's not going to tell what to do. You know, rapid tranquilization. Nobody will fault you for giving oral or IM haloperidol for this patient. That is not a problem. If a patient comes with bronchial asthma to your ward, and you notice the patient is depressed and the husband has died, right? And you feel this is depression, and you start fluoxetine on the patient, that is unnecessary, right? Because antidepressants take a long time to act. That is not an emergency, the depression. The emergency there is managing the bronchial asthma and trying to help the patient rather than starting. So understand where you stand. With a rapid tranquilization, you can always give it yourself. You don't need somebody else to prescribe it. You learn from the experience and attempt to prevent future attacks. How could you have prevented this? Keep the people who came, if you remember the scenario, is bought by co-workers and admitted to the surgical ward after a fight, right? So where are these two people? What happens is the nurses send them away, right? You're busy somewhere, you say, right? That is very important. One, to get a collateral history. Does this man have a psychiatric illness? Does he use drugs? The other thing is, if he starts fighting, there are two other fit laborers to hold him, his friend. So nurses always chase people away. When you do internship, you will see. දැන් හරි එකයි වෙලාව යන්න 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 ඔයා ගාව 12 ගාව ඉන්න ලඩාගේ කට්ටිය යන්න 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 කියන එක තමයි කියන්නේ, right? And to do their job they need that. I'm not blaming nurses, but from a doctor's point of view, one bystander, one caregiver being there is always helpful to get details, to make sure the patient can go to the toilet, to do a blood test if needed, and in this instance, if they're aggressive, to hold them. Get the senior opinion, psychiatry opinion early. ටිකට් එක ලියලිය ඉන්න වෙලාවනේ මේක වුණේ. ඊට කලින් මේ මෙහෙම ලෙඩෙක් ඉන්නවා මොකද කරන්න කියලා psychiatry inform කරලා තිබ්බනම් ඒ attendant ගහන්න කලින් the psychiatry MO will be say මල්ලි මම ඉක්මනට එන්නම් මේ ඉක්මනට මේ haloperidol ටිකක් දෙන්න කියලා, right? You could have informed the staff, minor staff ඔක්කොටම කියනවා මේ ලෙඩ කලබල වෙන්න පුළුවන් මෙයත් එක්ක පොඩ්ඩක් පරිස්සම් වෙන්න කියලා. So like that you have to inform and always do these things. So sometimes in emergencies, people who are obsessive struggle, people who do the right thing. ලෙඩා බලන්න ඕනේ, blood pressure monitor කරන්න ඕනේ, ටිකට් එක ලියන්න ඕනේ, full blood count එක ඉල්ලන්න ඕනේ. ඕක තමයි sequence එක. මෙතන මේ ලෙඩා psychotic. already ගහගෙන ඇවිල්ලා තියෙන්නේ. ඔතන full blood count එක, chest x-ray එක, අවශ්‍ය investigations ලියන එක නෙමෙයි වැදගත්. Right? You could have done a lot of things before that. So always remember, in internship, you have to be quick on your feet and sometimes do things a bit quicker than normal. Okay, all right. If you all have questions, you all can, once again, I know you all don't like to ask questions, but I don't mind that even. You all can send in questions on the chat as well. Okay, all right. Next scenario. Oh, sorry. A bit about rapid tranquilization. So once again, you all need to know what is there in your ward. When you go to your ward, emergency medicines, මොනවද කියලා දැනගන්න, right? ඔළුවේ ලොරසිපෑම් තිබ්බ කියලා දෙන්න එපා. ලොරසිපෑම් වාට්ටුවේ මේ දවස්වල ලංකාවේ නැහැ, right? පොත්වල තියෙන්නේ ඒක. So haloperidol is there. Go and ask what's the strength of the tablet. A lot of the time we at Ragama have 1.5 milligrams. So got a adequate dose එකක් 3 to 6 milligrams. Olanzapine we have 5 to 10 milligrams. Both are good. The benzodiazepine we have is clonazepam, that comes in 1 milligram tablet. So this you know. So when somebody is disturbed, you can give them quickly. You can repeat it in an hour. If they are very aggressive, if they are not taking oral, once again know the doses. IM haloperidol, IM midazolam, IM promethazine injections. Tell the nurses to give. You can give it rapidly. Rapid tranquilization can දෙන්න පුළුවන්. But remember, the haloperidol daily maximum dose is 20, right? So I think you can easily, as an intern, give 1 IM haloperidol. By then you would have contacted your SHO, registrar, or the psychiatry on-call team, and they would have taken over by then. ඔයගොල්ලන්ගේ level එකේ oral haloperidol 3ක්, clonazepam 1 milligram, IM haloperidol 5ක් දුන්නට කිසිම ප්‍රශ්නයක් නැහැ. You would have saved the situation. This is your second patient. Once again, there will be questions at the end. Send it to me. You all thought no more questions after finishing final MBBS. Unfortunately, life of a doctor is there will always be questions, which is a good thing, right? Answer this as well. A 36-year-old farmer is brought to the ward after falling down while working in the fields. His father says he had worked harder than everyone the last few days and hadn't stopped work even for lunch. But they noticed him to be swaying while walking. He mentioned that the son had an illness, Snayu Amarua, for which he takes treatment and regular blood tests are done. On examination, you notice prominent tremors of the hands. The patient is disoriented in time and place. He is afebrile, vital signs are normal, and rest of CNS examination is unremarkable. This is your scenario. You are the medical or house officer. Okay. These are your questions. 2 minutes. Send in one text each with 4 answers. On the main chat, please. Good. You all are improving. Well done. So these are the answers. Dehydration leading to lithium toxicity is the answer. Patient with bipolar. Current episode is mania. Nothing to suggest psychosis. Do serum lithium levels. And the treatment is IV, normal saline. Any form of hydration is good, but the ideal is IV, normal saline. And these you need to know very well. So a bit about lithium toxicity. It's a dose-related side effect of treatment with lithium. It's more likely if renal impairment is present. So check the EGFR stage. That is the important thing, not the creatinine level. The EGFR stage on the report is the best indicator, level 1, level 2, like that. Elderly, overdoses or dehydration, like in this patient. The symptoms are ataxia, the patient was swaying, poor coordination, muscle twitching, slurred speech, and confusion. It's an emergency, it's life-threatening thing because it can progress to coma and fits. Permanent neurological and renal damage is also reported. How do you manage it? Stop the lithium immediately, right? When you get overdoses, lithium toxicity, things like this in your ward, and you think this is due to a drug side effect or a problem, always remember as an intern, you will never write the medication. Make sure you tell the family also not to give it, because a lot of people give medicine, the bystander gives medicine, even then in the ward. So let's say a psychiatrist would have told this patient's mother or father, right? So you will be treating for lithium toxicity, and the government mama lithium. So always in your, and another thing that complicates things is when you're internship, sometimes we don't have all the medicine. So sometimes people actually bring from out and තියෙන බෙහෙත් ටික දෙන්න. දා එහෙම ඉතින් ඔගේ හයිබ්‍රිඩ් එකක් තමයි සමහරලාට යන්නේ. කලින් මේ බෙහෙතද ගත්තේ ඒක අපි ගාව නැහැ. ඒක ඕගොල්ලන් දෙන්න අපි මේ බෙහෙත දෙන්න. It becomes a bit messy. I would always ask, what are the medicines you all have? Okay. පාට්ටුවේ මොනවද තියෙන්නේ? හරි. අපි දෙන්නේ මේ ටික. ඔය ටිකත් මිස්ලට දෙන්න. අපි දෙන්නම් කියලා. Right? Then that sort of gets nullified, and that won't happen where you are giving the same thing by you and the family. To an urgent lithium level, we consider it toxic if the value is about 1.5 and above, but even over 1 is a bit worrying. Hydrate, right? Saline එක ගහ ගන්න හරි මෙලාවක් නැත්තම් මොකක් හරි nurse නැත්තම් cannula දාන්න හරි මොනවා හරි, or you can't put a cannula, you should be able to just tell them to drink water. Something with salt is ideal, so a juice is good, but even if the saline is there, tell them to drink water. It adds to the hydration. A normal saline drip. Monitor the input and output. That's important because they can go into renal failure. Daily serum lithium levels. If it goes very high only, dialysis becomes an option, right? But that's a rare thing, which once you do these things, your consultant will decide with a nephrologist whether that is needed. At your level, stop the lithium. Tell the family not to give lithium. Tell them to drink water, drink juice if they can get juice, and start a normal saline and monitor the renal function test and keep doing the serum lithium level. The first one comes as 2.3. The next day, it should be 1.2, like that. It will go down, so you know your treatment is working. This is your third patient. A 25-year-old garment factory worker is brought late at night by her friends in a hostel to the hospital. She has been receiving treatment for 6 months from a clinic since she had problems with sleep since she broke up with her boyfriend. The friends have noticed her fallen on the floor unconscious and an empty bottle of pills near her. She has written a note to her parents saying goodbye and sorry, and she loves them a lot. She is confused and does not give a proper history. She is febrile. You notice muscle twitching on general examination. Her pulse and blood pressure fluctuate while being monitored. This is your patient. Read it carefully. Right, now answer these questions. You'll have 2 minutes, like the previous one. Send more answers. Okay, answers are a bit less for this than the other ones, so I'll give you all 1 minute more. Think and send in your answers. It's okay to get it wrong today. Things are getting better. So these are your answers. So this is serotonin syndrome. Right? For those of you who didn't get it, who got it wrong, just go back to the scenario and you will see what serotonin syndrome will look like. Right? So this is the sort of picture: confused, febrile, muscle twitching, fluctuating autonomic symptoms. Right? So that is the sort of picture in the background of possibly being on a antidepressant, serotonin increasing agent. Right? So it's always the history that matters. Right? So what was this patient taking? What are these symptoms? So you correlate the two. Any antidepressant can cause serotonin syndrome. It doesn't have to be only an SSRI. The psychiatry, our sort of hypothesis, the biological hypothesis of depression is reduced serotonin causes depression, depressive symptoms. So any agent that increases serotonin, so the tricyclics, amitriptyline, imipramine, fluoxetine and sertraline are the SSRIs, venlafaxine is a SNRI, all increase serotonin at some level, and all these medicines are available in government hospitals. The underlying diagnosis is severe depression, right? Once again, go back to the scenario, right? You will see patients with adjustment a lot, right? You all will see patients who have taken 10 tablets of paracetamol come. Boyfriend text kare na SMS එකේ blue ticks දෙකක් තිබ්බා මම ඒක බැලුවා එයා දැකලා තිබ්බේ හැබැයි එයා reply කරේ නැහැ ඉතින් මම මේක අරගෙන යාට photo එකක් ගත්තා මම ගත්ත පෙතිවල that is impulsive, right? The patient had been ඊට කලින් මොනවද කරේ ඊට කලින් දවසෙත් මම ඉස්කෝලේ ගියා දැන් මොනවද කරන්න ඕනේ හෙට මට පන්තියක් තියෙනවා යන්න ඕනේ boyfriend උත් කතා කරා. That is adjustment, right? Not to take her seriously, but you know that this is not a serious suicide attempt. This is not serious severe depression. Here you will see things. She has broken up with her boyfriend 6 months ago. By about a month, adjustment disorders usually settle, right? Receiving treatment. So somebody thought she was ill enough to start treatment, right? Don't negate that. Not sleeping, right? And now found unconscious. එතකොට මේක පැන්ඩෝල් පෙති 5ක් 10ක් මෝටින් කොයිල් එකක් පයිනෝල් ටිකක් බිව්ව නෙමෙයි, right? Consciousness නැති වෙන level එකේ overdose එකක්, right? She has written a suicide note, a final act. So remember that this is suggestive of severe depression. This is a serious attempt. So what do you do? What is the single most important thing you will do? Tell them to stay in the ward till someone from the family arrives, right? Because her problems have not improved by coming here. She is not safe by coming into your ward. Her problems have, what are her problems? What has happened to her problems? Her problems have worsened. Earlier, she was at least in a hostel alone crying. Now she is in a crowded ward, possibly put on the floor because there are no beds on casualty day. There'll be people scolding her for doing this, and somebody would have tried to put a cannula or taken blood from her. She is in pain. She is worried. People will shout at her. She is high risk, right? We have had issues where people have come into medical wards after suicide attempts. In the hustle and bustle of a medical ward, no intern can wait with her. The intern has to go and see the myocardial infarction and the stroke patient and the dengue patient. There is no attendant to leave with the patient. They are more busy going for x-rays. Nurses are even more busy giving medication. The patients have walked out of the ward and gone and jumped into the train. Right? So a chance to save a life is lost. And until the patient comes and suddenly you hear a news and ETU eකට ලෙඩෙක් ගෙනල්ලා කෝච්චි එකට පැනලා and you realize this is that patient who was in your ward half an hour ago, right? So always remember practical things. You can't treat this lady's depression. You can't bring the boyfriend back. There are things you can do and can't do, but you can tell the friends to stay with her, and keeping her safe acutely till she solves her problems. So psychiatry solves her problem. You have done your job and you have saved a life. And that is what is important as an intern. So a bit about serotonin syndrome. It's a neurotoxicity syndrome seen when medication used to potentiate serotonin is prescribed. It's seen with high dose antidepressant use, right? When we treat anxiety disorders, OCDs, we give higher doses. When there is severe depression, we combine antidepressants. So look at the prescription. Patients will have prescriptions, clinic files, ask them to bring what they are taking. You will see a few sertraline and imipramine combined, right? So you will give that. Sudden increase in dose, or like in this instance, an overdose can cause it. These are the symptoms of serotonin syndrome. Myoclonus, that's the twitching. Myoclonic jerks are seen in serotonin syndrome. Nystagmus, headache, tremors, rigidity, seizures are seen. Psychologically, there is irritability, confusion, agitation. They can become hypomanic. They can be overactive because the antidepressants can increase your mood. They can be in a coma. Then there will be fever, sweating, diarrhea, postural instability, and cardiac arrhythmias can be seen. So remember, you get a odd sort of a picture of a very unwell patient and they have been on antidepressants. Suggest it to your consultant, suggest it to your registrar or SHO. This patient has been taking fluoxetine. Now he's confused. Could he be having serotonin syndrome, right? That is your duty as an intern, and sometimes you will end up picking things which the registrars and the consultants board, which is what a good intern should be doing. Avoid combining medication when you're giving. That will stop serotonin syndrome, but that is for other people. It's not your concern. Early identification and high degree of suspicion is important. Distinguish this from NMS, which is an important comorbidity. Stop the medication immediately. Like I said, tell the family also not to give. SSRIs have long half-lives, and this might take a bit long to act. Provide supportive management, that is hydration, measuring pulse, BP, urine output. Those are important. There are specific anti-serotonergic agents, cyproheptadine, peritol killer, those are given as appetite suppressants as well, but they help with this. You can treat that, and propranolol also helps. So identifying is important. Supportive management is the key, and stopping the antidepressant. Okay, fourth patient, right? Two more in your a 20-year-old university student is being treated for fever and severe gastroenteritis. He is on oral ciprofloxacin, IV saline, IV metoclopramide, and paracetamol. You are informed that the patient is behaving abnormally. When you examine, you notice his eyes are rolled up and he is in distress. His neck muscles are extremely tight and he is unable to speak. The patient is thinly built, has a tattoo on his forearm, And on the admission notes, you notice alcohol and cannabis, occasional use mentioned. So this is your patient. You're the medical house officer. These are your questions. 2 questions. Quick answers. Yeah, so most of you all have got it right. This is an acute dystonic reaction. And the important thing is write it on the card clearly. Sometimes just managing the patient is not your only duty. And this is something I hope all of you all will do. Take pride in your diagnosis cards, right? It is a large part of the management. Whenever you see a patient, what do? Calling cards, right? Patients don't have to, but some patients laminate it, keep it, photocopy it, and they bring it. And it's nice to see, even when you're, sometimes we see our own cards and realize, my God, and sometimes you think, I have done a good job. Sometimes you think, my God, I must have been very busy or lazy. This card is useless, like that, but it helps, right? And it will help you. And it is possibly some of the only ways your work is documented. So always write it clearly, neatly, and put the important things. Have a red pen with you. Put those things. Those are life-saving. Whenever I see a BHT which is not clearly written by a doctor, or a diagnosis card which is not clearly written by a doctor, I always think this patient, this doctor is selfish, right? They have passed all these exams. When there were marks to be gained for themselves, they had the ability to write neatly. But now when it's for somebody else, their handwriting has suddenly deteriorated. It's not I don't find it funny, or that doctor's handwriting is not nice, or it's not something to be proud of. We are too busy. We are so busy. No, I mean, how tough was the A-level biology paper? We didn't have time to write it, no. But we wrote it clearly, no, to get marks, get an A. And how difficult was the final MBBS medicine paper? There was no time, but we wrote clearly and got good marks to pass. So if we can do that, we can write these things clearly on this card. So please try to do that, and that is a sign of a good intern. So acute dystonic reactions occur soon after treatment started with antipsychotics, but not only antipsychotics. That's an important lesson here. Certainly with patients with who are on psychiatric treatment, it's more common, right? But here, metoclopramide is given much more than any antipsychotic. So a lot of acute dystonic reactions occur with metoclopramide. Young males like this are more prone to develop it. Typical, if a patient has been given IM haloperidol, it's more likely. So if you are giving things like that, it's important. Torticollis, a neck moving to a side, tongue protrusion, grimacing, and opisthotonus are also likely to cause it. It can be easily mistaken for psychotic behavior. So this patient was actually referred, if you look at this scenario, the patient's referral came as abnormal behavior due to cannabis-induced psychosis, right? Because young person smoking cannabis, now behaving abnormally, the doctors thought this is something to do with cannabis. So don't be judgmental, always go through your clinical signs. Cannabis-induced psychosis doesn't present like with a tongue put out. That is an acute dystonic reaction. Stopping the medication is the most important thing. And the treatment of choice is IM benztropine, which check in your ward if it's there, right? If not, IM promethazine, which is available, will also help. If they can swallow, oral benzexol, oral benzodiazepines are useful. But remember, if somebody has can't swallow due to the acute dystonic reaction, don't put pills into their mouth. Documentation is very, very important. Okay, going into the last scenario. Okay, this is your last patient. Answer well, end on a high. Okay, a 23-year-old patient with polysubstance misuse becomes aggressive on the medical ward. Your consultant asks to administer IM haloperidol 5 mg stat and refer to the psychiatry unit. The psychiatry MO sees the patient, starts the patient on oral haloperidol 3 DD and asks to arrange transfer to the nearest psychiatry unit. Prior to transfer the next day, the nurses mentioned his temperature is 101 degrees and he is not moving or speaking. So read your scenario well. These are your questions. Quick answers, quickly. Everybody send in. Last patient. This is the scenario. These are the questions. Okay, I want a few more answers. Once we're sending it properly. Okay, good. Right. Yeah, so these are your answers. This is neuroleptic malignant syndrome. The cardinal features are high fever, disorientation, generalized rigidity. That's why the patient can't move, and autonomic instability. A CPK level of over 1000 will most likely confirm the diagnosis. CPK doesn't rise only in NMS, but with the history of antipsychotics, with the clinical picture, it's most likely NMS. Clonazepam helps control the symptoms as well as control the behavior. Bromocriptine and dantrolene are also useful supportive managements. So just a bit about NMS before we end. It's a rare but life-threatening condition. Even though because it's life-threatening, it's a medical emergency, right? And you will see them in the medical wards. About only 0.2% of patients treated with antipsychotics will get it. Come early. So remember, the features can be generalized rigidity, dysphagia, dyspnea, altered consciousness, stupor are there. You will have a unstable picture. Suddenly the blood pressure will be high, suddenly it will be low. Tachyarrhythmias, increased sweating are there. These are the complications if it's not managed properly. You can get pneumonia, thromboembolism, CVS collapse, and renal failure. So you'll be monitoring the renal output well. You'll be monitoring the patient very well. Mortality is high. Ideally, supportive management in an ICU. Once you go start your internship, you will realize ICU beds are very precious. You might not be able to get it, but then ideally in a medical ward. These are the specific treatments. But if you give supportive management, that's enough. You have to wait 2 weeks to start an antipsychotic. That also the medical psychiatry registrar will do. Okay, so we come to the end of our lecture. All intern house officers should be adept at managing an aggressive patient. Prevent them becoming aggressive. That's the key. After becoming aggressive, it's not easy. Prevent the risks. That is the most important thing. Look after yourselves. Your lives are precious. You're a very clever, capable people. Aggression happens in wards. And look after yourself so you can help others well. Know the features of neuroleptic malignant syndrome, lithium toxicity, serotonin syndrome, and acute dystonic reactions, right? These are emergencies which you will have to help. You need to identify these, start basic management, and inform seniors, right? If you do that, you would have done well. So once again, all the best. It's an honor to speak to you all because you all are the future of medicine, and you all have succeeded in more stages of your life, every stage, and this is another important stage which I'm sure all of you will pass with flying colors and go on to become very successful doctors. So all the best and thank you.
Right. That was Dr. Charman Vijayasinghe, Senior Lecturer and Consultant Psychiatrist at University of Ragama. So thank you, sir, for that comprehensive session on psychiatric emergencies. So thank you once again. So next up is suicidal risk assessment by Dr. Gihan Abe Wadana, Consultant Psychiatrist at National Hospital, Kandy. I think sir will join now. Yeah.
Hello? Hello? Sorry, can you hear me?
Yes, I think I just spoke to Doctor. I think you are doing the lecture, madam. No?
That's right. Hi.
Hi. Right. Sorry, I'll just make you a co-host. Right. So this Professor Tilini Rajapaksha, Professor in Psychiatry. So over to you, madam. You are doing the same topic as Dr. I'm not, it's not updated on my agenda list.
Supposed to be doing assessment of suicide risk.
Okay, madam. Yes, yes.
For the next half an hour or so. Yeah.
So you can start, madam. Yes. Can we move few slides and see whether it's moving?
Yeah.
Okay.
Okay,
All good to go. Yes. Over to you, madam.
Okay, thank you.
Right. You're welcome.
So good afternoon, everybody. And I'm Tilini Rajapaksa from Peradeniya. And I was supposed to talk to you about assessment of suicide risk, which is, I think, a very relevant topic for everybody, for many people who are not psychiatrists, because you know, as interns, you will see a lot of people presenting with attempts of self-harm or attempt of suicide. So once you manage the medical or the surgical problem, your question will be, how risky is this person? Can I discharge them? Do I need to refer them elsewhere? So that is why you need to know this, a quick bedside assessment of suicide risk. So that's what we're trying to cover for the next half hour. And I have to start by saying that assessment of suicide risk is an overall assessment. It's not, you don't look at one aspect in the self-harm attempt and make a decision. You look at the whole picture. And having said that, I'm sure most of us, many of you, have already done suicide risk assessments. Okay. And, you know, without even realizing it, I'm sure you have done it. So to prove that, I'm giving you two examples, okay, there are, so if you can see the screen, okay, example A, now I'm going to ask you to read this and then tell me or put in the chat who you think has a higher suicide risk. So example A is a 17-year-old schoolgirl who takes 10 tablets of her mother's medication. She has an argument with her sister. She gets angry. She sees the mother's medication on the table. She takes it. And then she tells her mother what she did. And she's not depressed. Example B is a 59-year-old man. Now, he has also had a quarrel, this time with his son, and he has ingested pesticide. And he had the quarrel with his son. Then he went to a shop, he bought the pesticide in the morning, kept it with him, then drank it at night when he was alone in his room at home, and then went to sleep. And he's also alcohol dependent. And there is a story that, you know, the family says he's a bit irritable and lethargic. So now if I ask you the question, who has a higher suicide risk? I think it's a no-brainer, fairly obvious. Oh, good, I'm getting some answers. Yes, everybody's going B, 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 and I completely agree. Example B has a significantly higher suicide risk. And then example A. So the process, sorry, can you see the screen? Yeah. So the process that which you did, you know, what you did now to decide that is what we call suicide risk assessment. Okay. So I'm just wondering, okay, yeah. So that process is what you call suicide risk assessment. And all I'm going to do for the next 20-30 minutes is try to break down how we did that assessment. I'm sorry, can you see the screen? I'm going to stop it for a minute and try share it again. Okay. Can you all see the screen now? Am I sharing it? Okay. So we're just going to break down this process of how you decided this person has a higher suicide risk. So, like I said, it's an overall assessment, but often the place you will start with is the suicide attempt. Because in your day-to-day working life, a lot of the time you will be assessing risk is when somebody presents either with a drug overdose or pesticide injection or an attempted hanging to the surgical ward. So that's the place you'll be starting from an attempt. So let's see, how did we decide that this B is more risky than A? So if there is a recent attempt of self-harm or suicide, you look at one thing is, the actual attempt, the circumstances. You're trying to understand how much did this person want to die? So you look for clues. So you look at how much did this person plan the attempt? So if they planned it a lot, so if you think of the young girl, she had not planned it at all. She saw the medication, she got upset, she saw the medication, she drank it. Whereas if you think of the man, he also got upset after a conflict, but he went to a shop, he thought about it, he bought it, the pesticide, he kept it with him. So he was planning it. And also, so that's what I'm trying to say. Okay, so planning could be in different, now that was in these two examples. Other examples of planning and premeditation means thinking about it is, over the past few weeks, the person may have told about it, talked about it. Often what we see now is people sometimes Google methods to die, look it up. Okay, they, if it's an overdose, you might collect medication, you might go from pharmacy to pharmacy, using the same prescription to collect different meds. Now, in this case, this man bought the pesticide and kept it with him. Occasionally, you will see things like suicide notes and last wills. So if you see this, if you see this kind of planning or premeditation or anything that makes you think this person was thinking about it for a while, you get a little more worried. Your risk is going to the higher side. Okay, but remember, it's not just one thing, but that is indicating a higher risk. Okay. Right. So then what are the other things you look for in the circumstances? Another thing you might look at is, did the person, looking at the attempt, did they want to be sort of saved or did they not want to be saved? Okay. So attempts to prevent discovery, calls for help. Now, in our first example, the girl did it probably in front of her mother, and she also told her mother. So people tell in different ways. They might call, they might send a WhatsApp message, or they do it in a way that they know they get found out. Whereas our older man, he took it at night and went to sleep, because when you go to sleep, you assume that for the next few hours, nobody will come and disturb you. So your chances of being discovered are less. Similar, sometimes people might go to a faraway place and drink pesticides or lock their room or take steps so that nobody will discover them and save them. So if you have circumstances where the person planned it a lot, then took steps not to be found out, you are more worried. The other part you might look at in the circumstances is the lethality or the perceived lethality of the method. So what do you think, what would you be more worried about? Somebody taking a drug overdose of, 15 tablets of paracetamol or attempted hanging? What would you all worry about more? I think most people will be more worried by the attempted hanging because that's a more violent method. It needs a greater degree of intent, a stronger desire to die. So attempted hanging often is you're more worried about that. Somebody who's taken a potentially lethal pesticide versus 10 tablets of paracetamol, like we did in this example. Again, the pesticide, you're a bit more careful about. So that's what I mean by lethality of method. Of course, you have to take into account how lethal the person thought it was also, or the patient. Because sometimes a young person may be quite depressed and have a high intent of suicide, but may think 10 tablets of paracetamol will kill them, whereas we know it won't. Okay, but you need to sort of understand how lethal the person thinks it is as well. So these are what you look for in the circumstances of the recent suicide attempt. And just having a suicide attempt recently also increases your risk. Okay, so now one aspect you look at is, did the person have a recent suicide attempt and what were the circumstances? So that itself will direct us towards whether there is a high risk or a low risk overall. But then there are other things also. Okay, so now the person gets admitted, maybe for an attempted hanging. You treat any injuries or any lacerations, and then the person has recovered and wants to go home. So then you're thinking, can I discharge the patient or not? So one of the things you do is looking at the circumstances of the attempt, but you also then, then you might ask, was there anything else in the background? So one of the anything else is, does the person have previous attempts? The more attempts the person has had, often the more the risk goes up. Also, if they've had a recent other attempts, you're more worried. The other thing you look for in the background is, did this come out of the blue? Was a person completely well until this conflict and they attempted self-harm? Or is there a background suggestive of perhaps depression or alcohol use disorder? Those are the two common ones. Can I just ask anybody who's got their, to mute your mics? Thank you. Okay, so you ask what happened, why did this happen, how did you do it, to get the circumstances. Then you ask, did you ever do anything like this before? And then you ask, apart from this, has there been anything else different over the past few months for you? Have you been sleeping okay, eating okay, difficulties falling asleep, any particular worries, difficulty concentrating? So you're sort of putting a feel out for depression. If you have a collateral in history, it's even better, but you can always just get it from the person. You know, how have you been? And also a clue is, were you working? Were they doing what they usually do? If it's a student, were they going to school? Young person, were you going to work, university as usual? Or was there a change? If there is a psychiatric comorbidity, particularly depression or a substance use disorder, your risk goes up, particularly if they're currently depressed. Which brings us back to another thing that I'm putting up here. So you look at whether the history is suggestive of a psychiatric illness, and then you also, during your whole interview, when you talk to the person also, what their current mental state will also guide you. So sometimes you might have somebody who says, you know, the young girl, the 17-year-old who took her tablet, she might say, I just did it on the moment. I'm so ashamed now. My mother cried. I am upset about it. I'm never going to do something like that again. And then, you know, I had a lot of injections and I don't want to ever do this again. I want to go home. So where they are not depressed, they are regretting the attempt, they have no current suicidal ideation, then you're more comfortable. Your risk is going down. But on the other hand, you might have that elderly man who, you know, took the pesticide. He might, you know, when you look at him, he may look depressed. He doesn't, you know, he avoids eye contact. He's looking down. He's not really engaging very much. When you ask him, what do you feel about, what are your thoughts about having done this and survived? He doesn't answer. Do you still think, or do you still have ideas about ending your life or harming yourself? He avoids eye contact and looks down. Remember, if somebody's not answering you, that's also dangerous. Okay. So, or he says, මට දැනුත් හිතෙනවා මැරිලා ගියා නම් හොඳයි කියලා. වෙලාවකට ඒ වගේ දෙයක් කරගන්න හිතෙනවා. So that's current suicidal ideas. If you have those, obviously your risk is going up. Okay, but so which means that so you ask about the attempt, you look for psychiatric morbidity, and then during your conversation, you keep your eye out for current depressed mood, current suicidal ideas, regrets about surviving. Okay, obviously, if they have things like hopelessness, where they are saying, I have nothing, I have no future, there is nothing for me, then your suicide risk is going up. And if the person has psychotic symptoms, definitely, then that person needs a psychiatric referral. Okay, so you move on from circumstances to psychiatric morbidity to their current mental state. And the other thing you think about is, does the person have significant stresses? So, for example, you might have a woman, a 45-year-old woman, who has a conflict with her husband and takes 20 tablets of paracetamol and gets admitted to hospital. And on examination, she's quite recovered now, and she says she wants to go home to look after their 4-year-old child. But then she says, "Doctor, I want to go home. I will never do this again. Or maybe, I can somehow face things." But then you ask her, what do you have to face? And then she talks about she has significant marital conflict, domestic violence in the house. And, the reason she took the overdose was the husband comes and, is violent every day. And this day he had taken her head and, smashed it against, pushed her against the wall, and she hit her head. And she got so upset at that moment, she decided she couldn't go on, and she took an overdose. But she's also now going home to the same situation. So she might not even have a psychiatric morbidity, but there is an ongoing significant stressor which can precipitate further attempts. So obviously here you have a problem, because it may not be antidepressants that you need, but you might need at least some counseling or social worker input. So that would increase your risk. Okay. Anything else that you all can think of that you consider in suicide risk assessment? Sometimes people will talk about things like age, gender, and access to means. So generally, do you all know which age and which gender is suicide higher in? Is it in completed suicide? Is it highest in young people or older people? So completed suicide is higher in older people. Okay. So suicide risk actually increases with age and increases with male gender. Now that's a very general statement. So obviously every individual is different, which is why I've put this at the bottom. Okay, so just the moment you see somebody, you don't, look at them, you have 2 people with overdoses, one person is 25, the other person is 60. Just because of the age, you can't say that person has a higher risk. But it's one of the contributory things. So you're a little more worried about somebody who's older. So this really, in the nutshell, is your assessment of suicide risk. This is what you have to do. Okay. To summarize, after the person recovers from the attempt, you talk to the person and you assess with regards to the suicide attempt. Did they plan it? Did they take steps not to be found out? That increases your risk a little. Okay. Then you talk to the person. As you do that, you try to judge, does the person have anything, a history suggestive of depression, alcohol use disorders? If you see that, your risk is going up. If you see previous suicide attempts, yes. Then as you talk to the person also, if they are currently depressed or have suicidal ideas or regrets about surviving, and they have a psychiatric illness, and they're an older person, you're really going to be careful. That's a reasonably high risk. Okay. Or they have ongoing significant stresses, which you think they don't have support for in an older person with a little bit of depression. Again, you're more worried. I hope this is making sense to you all. What I'm trying to show is that it's multiple things. Okay. And you look at the whole picture and you weigh it up, and then you make a decision, which you did already in the first example. Okay, so it's not difficult. I just broke it down into pieces. Okay, and if nothing else, just remember that if the person has had previous attempts, your risk goes up. If the previous attempts are recent, so 2 weeks ago they took an overdose, and now they are coming with an attempt and hanging, you are quite worried about them. And if they are a little depressed and they're an older male, even more worried. Add alcohol use to that problem mix, and you're really going to do a psychiatric referral, hopefully. Okay, and not discharge him directly. Okay. So that's what I'm saying. The more recent attempts, the high. Yeah. Anybody coming in with a question? Oh, that was a mistake. All right, so that's really what I had to say to you today. But I'm happy to take questions or comments in the chat box. Anyone? No? Any questions or anything that's not clear? All right. So that's a very brief. Oh, yeah. Good. I'm seeing a question. Oh, at least something. So somebody's asking, what does that mean by completed suicide? Suicide means, so the definition of suicide is somebody has just done something which, deliberately, purposely, knowing that they might die, and they died. So there's a fatal act. Okay. So suicide and completed suicide, both are the same thing. When you use the word suicide, you are saying the person is dead. If he committed suicide, he is dead. If you're saying attempted suicide, the person has made some sort of attempt with a suicidal intent, but they have survived. Okay. I hope that helps. Good. Any other questions in the chat, or anybody wants to unmute and ask? Because we have a few minutes, I think. Yeah. Yeah. Any other questions? Okay. So that's really the summary of what I was talking about. All right. So I might actually stop unless somebody has any last minute questions. Okay. All right. I hope that was useful. Okay. I'll be stopping there. Thank you very much for listening. Okay.
Thank you very much, madam. That was Professor Tidni Rajapaksha from University of Peradeniya on the topic of suicidal risk assessment.
Okay.
So next up is another important lecture by Dr. Shanika Mendigama, consultant psychiatrist based hospital Teldeniya. Liaising psychiatry when referred to a psychiatry board, I suppose. Yes, madam is logged in, I suppose. So she will start the sessions for a few minutes. So Madam, I have given introduction. Madam can start. I can see your slides. You need to make it full screen, madam.
Should I make it full screen?
Not yet, madam.
Okay, I'll make it full screen. Can you see it now?
Better, madam. Yes, yes. Can you move for a few slides? Yeah, it's working. You can start from the beginning.
Okay, right. Okay. And I think the introduction was given. So I'm Dr. Shanika Medagama. Today we are going to talk about liaison psychiatry. So I hope that you have worked in the psychiatry units for about 2 months, I think, in your medical student period. So you must be you must be familiar with liaison psychiatry. So let me introduce you into liaison psychiatry with more details. So in shortly speaking, what liaison psychiatry is, when in the medical wards or the other medical disciplines, when you see patients related to any kind of related to psychiatric illnesses or the management, we refer from the medical sides or the gynae sides or pediatric. These sides, we refer patients to the psychiatry unit. So in short, it is called liaison psychiatry. The purpose of that is we know that mind and brain, mind and body works together. So in the purpose of it is to give the best treatment for the patient, best management for the patient. So it is very essential. So as psychiatrists in Sri Lankan hospitals, we all do liaison psychiatry, and also as interns, you will be appointed to the hospitals where psychiatry services available. So you will see patients who need care and by the psychiatry side. So we will go through some slides and see that who will need psychiatry assessment and who will need to be referred to the psychiatry units. So in short, what is liaison psychiatry? So in different instances, we need working together with the psychiatrists. So first is diagnosis of a mental disorder in those with a physical illness. We know that there could be comorbid psychiatric illnesses in a patient with medical illness. So in that case, we need referral to psychiatrists. For an example, if a patient has hypothyroidism, and if you see that the patient has features of depressive disorder, so in addition to management of hypothyroidism, we need to refer to the psychiatry unit to manage the other psychiatric comorbidities of that patient. And also, many times we encounter when patient has a medical illness, physical illness, they have some psychological factors which affect the recovery from the physical illness, such as in diabetes. If someone has diabetes, sometimes patient won't take medications because some other factors, maybe there is comorbid depressive disorder, comorbid other mental health disorders, or treatment adherence is not good because of the psychiatric conditions. So we need to get the best optimal management of the psychiatric factors for the patient to have a better recovery from his or her physical illness. And also, medically unexplained symptoms. This is very common in the OPD sector, and also you will see them in the medical clinics or the other clinics. So we do medical sides, surgical sides, we do investigate, but the patient persistently come up with the same symptom or different symptoms. And then the other disciplines of medicine cannot find any reason that why this patient is having this condition. So it could be due to psychiatric complication. So in those instances, also the medical sides or the other sides refer the patients to the psychiatry for psychiatry opinion. And fourthly, we know that there are many medications. As you all know that there are many medications are used for treating psychiatric illnesses. So in the physical illness, when someone has a physical illness, we need to discuss with the psychiatry team whether we need to continue treatment or whether alteration of the doses of medication is essential. If the patient's renal functions or liver functions are altered, whether to continue these treatments. So we need to have a collaborative management in giving medication for the mental illnesses. So continuation of the medication given for the mental illnesses. And also sometimes psychological therapies will be needed for someone who is having a physical condition. For an example, if someone has a cancer, sometimes we may need to start on antidepressants or address the psychiatric issue, and also sometimes it will be helpful to give some psychological therapies. So in those instances also it will be very helpful. And as I mentioned, the complex cases such as kidney failure, liver failure, those cases, and with multiple medical and psychiatric conditions, we need to be seen, the patient need to be seen by a psychiatrist. So in different instances, we need to refer, maybe to get the consultation to diagnose a psychiatric illness and for collaborative management plan. And also we need to have an ongoing communication regarding the holistic management of these patients. So it has to be done in a very friendly way. So I know that you have got the training in psychiatry, and also you had your final exams, psychiatry subjects. So rather than the previous trainees, now you have a very good training in psychiatry. So if you identify someone whom you think will need psychiatry opinion, you always better to talk to the senior registrar in the unit or consultant in the unit, and then make a referral to the psychiatry unit. So our teams are very ready to help you at any instance. And at the main time, sometimes doctors refer patients just with some superficial examination. Sometimes when the patient is not speaking or when the patient is just withdrawn, sometimes referrals are made, or sometimes when the patient cannot be discharged, psychiatric referrals are made. So I think that those instances, actually, you need to do a thorough psychiatric assessment to see whether there is any need by intervention from the psychiatric team. Otherwise, it will not be a proper referral. So we will see that how liaison psychiatry can be helpful. So you know that you will be encountering patients who comes with overdoses and cut injuries or any deliberate self-harm. In those instances, you need to assess risks at your level and communicate with your seniors. And then if you refer the patient to us, the patient might need in-ward treatment in the psychiatry unit. In those instances, we can help by arranging a bed in the psychiatry unit. And also sometimes somebody who is on treatment at psychiatry, at a medical unit or a physical health condition, so you might need to identify triggers. Why this patient is getting this illness recurrently, or why this patient is not taking treatment. So our team can help in identifying the triggers. And also, as a house officer, you will be encountering patients with acute behavioral disturbances. So it's we are aware that we can't, the patients cannot be managed sometimes in the medical wards because of these behavioral disturbances. But if the patient is having multiple medical complications, while the patient is in the medical wards, we help you all to manage these behavioral disturbances, and collaboratively we can make decisions regarding what medications will be needed, how to control the behaviors. And also, we help in advising changes in psychiatric medication and contraindication. Sometimes with lithium, some medication could be contraindicated, and with clozapine, some medication can be contraindicated. So we are there to discuss about that, and you can, with your senior doctors, we together, we can modify the treatment and give the optimal care to the patient. So I think in the previous sessions, previous lectures today, you might have got the idea regarding this capacity. This is also something very commonly we see, not very common, but we encounter patients. Sometimes if you are working in a surgical ward, patient might say that he or she doesn't want to undergo surgery. Or sometimes, recently there was a patient in the medical unit who came with constipation. The patient says, no, I don't want any suppositories or anything. So in that case, the medical teams refer the patients to psychiatric services to check whether the patient has capacity to come into that decision. As you all know that as adults, we can give consent to patient for certain procedures, and if we are not willing, we can say no. But we need to see whether the patient has the capacity to make that decision. So psychiatric team will be very helping you in making that decision. So these referrals also come to us. And other things are psychiatry means it is risks, mainly risks are very important. So sometimes you might see a patient who is vulnerable to get abused by someone, vulnerable to get exploited by someone. So risk of vulnerability, especially this is common in elderly patients, maybe financial exploitation or the exploitation in emotional abuse, and also in learning disability. Learning disability, we'll have to be very careful because they can't sometimes verbally express what they are going through. So if you see any vulnerability to exploit, vulnerability, any kind of vulnerability, it's always important to discuss with your seniors and make a referral to the psychiatry units. And as I said, the risks are very important. And it is your duty also as a citizen and as a doctor, it is your duty. If you see a risk, suicidal risk or risk of homicide, we always, the medical teams or the other doctors need to refer to psychiatry because we need to immediately take actions to minimize the risks in this patient. And on discharges also, we might sometimes come and see a patient there. On discharge also, we need to continue the management, continue the best care for the patient. While the patient is in a medical ward, and if we have seen the patient before discharge also, it is very important to discuss with the psychiatric team regarding how we are going to discharge this and what is their the psychiatric team's follow-up management. So always we are here to help. Psychiatric teams all around the country are here there to help. If you talk to the psychiatric team so we are there to help in making, formulating care plans for the patients. And also, as psychiatric team, we have good access to the social service departments and also child welfare and children's and women's caring officers and police and the social services NGOs in the area. So if you think that if a patient needs some help, maybe some financial helps, maybe on discharge, if a patient is having problems, So the psychiatry team knows that what are the services available in the community. So you can always discuss with the psychiatry team after referring through your seniors. So we can, you also can access these services, NGOs and the government services on providing the maximum and best care for the patient. I will give you some examples, such as that recently there was a patient who was admitted to the pediatric ward with the neurological complaint. He says that there is a numb area in the leg. So the medical team has assessed and there was no physical causes found. But on assessment by the social worker and the psychologist, we found that the child is going through a lot of difficulties. So we had the case conference and we gave some support in building a house and also sending the child to school, and financial difficulties, how to handle the financial difficulties. So like that, the psychiatry team is there to get the give the help, appropriate help in managing this patient in a biopsychosocial way. And I need to talk about this. This is a very important thing, that sometimes because of stigma, patients with psychiatric illnesses, if they are admitted to the medical ward, so the other medical disciplines, sometimes we also have that stigma. As doctors also, still the stigma in the community we also have. So the care may be little less, and also the optimum available treatment, we might be thinking that whether the patient is suitable for the best treatment. For an example, cataract surgery in a patient who is having bipolar disorder. I have the experience, sometimes the eye surgeons might not like to do a surgery because of this stigma and the fear that the patient might not behave well after the surgery. So it is therefore always necessary working in collaboration with the psychiatry team while providing the optimum treatment for the patients. And also the studies have shown that life expectancy of patients with mental illness who is having comorbid medical illnesses, the life expectancy is 15 years less. It is because there could be various reasons where patients might not be going to get treatment and might not be diagnosed. So it is our duty as you are starting jobs as new doctors, always give the same care, optimal care, while a patient with psychiatric illnesses is admitted to the medical side. So you can, for the management of that patient, you can make a referral to the medical psychiatry side. And if there are any behavioral disturbances, we are there to help. And by that way, we can make the best management option for the patient. And other thing is that always, as you have good training in psychiatry, always think whether this patient could be having, whether the patient is having any psychiatric complication, a psychiatric illness leading to this kind of presentations. Otherwise, sometimes after a lot of investigations only we get the patient to the psychiatry side. So therefore, early detection of psychiatric illness and possibility of psychiatric illness might reduce this impact on the patient, because sometimes patients can go into these unnecessary investigations and damaging investigations. Some interventions could be damaging. So therefore, it's very important to have a psychological minded doctors to see these symptoms, whether these could be due to psychiatric illness. I remember a patient who was admitted, who was treated by the surgical team for years because the patient, elderly lady presenting with bowels are not working. So all invasive investigations done, including colonoscopies, endoscopies, and CETs, MRIs, and a lot of investigations done and treated for 2 years. Later on, the patient came to psychiatric services to see that this patient has severe depression with weight loss and these nihilistic delusions, thinking that the brain is, the bowels are not working. So if you had the psychological minded doctors, so the referrals could be early. Therefore, if you suspect that these symptoms could be due to psychiatric illness, it's always get your senior's opinion and refer to the psychiatric services. And as you all know, having a psychiatric illness is a lot of disability, and quality of life is also less if you don't treat. Therefore, this looking for psychiatric comorbidities and appropriate treatment is very essential. So as the doctors who are starting your career, it's always use your knowledge in psychiatry and discuss with your seniors and refer to psychiatric services, and we can two-way collaborate. We can collaborate with you for the management of these patients. And also, why this is important, I'm discussing the cost of treating diabetes. If the patient has comorbid medical depression together with diabetes, the cost of treating diabetes is higher. If the patient was not treated for depression. So if the patient was treated for depression also, the cost will be less. And the longer time to recover. If the psychiatric illness is not treated, they take a long time to recover and affect recovery. If patient might not recover to the 100% and patient might recover less, because there is underlying psychiatric condition going on. Therefore, it's always necessary to look whether there could be a psychiatric illness. So, and currently, I think more and more referrals come from the other specialties, and the psychiatrist work also getting more and more busy. But I think the overall outcome as patients, for the patients, is very good. Currently, I think because of this training you have in psychiatry. And let's see that when to refer these patients, whether it's urgent referral or a less urgent referral. So what are the instances that you will need to refer urgently? So you will be having opportunities to work in the emergency units and medical or surgical units. So deliberate self-harm. Deliberate self-harm, you know how to assess risks and how to see the severity of the risks. And if you think that there is urgent need to be seen, always refer. And also, it's better to refer all patients coming with deliberate self-harm. And if there is if the patient divulge information related to harming someone, please, it is our duty to refer to the psychiatric services while making measures not to make that harm. And as I mentioned, vulnerable patients, especially elderly patients and learning disabled or the children. If you see anything regarding safeguarding issues, please refer. And also sometimes patients come with neglect. Patients might be not attending to their cleanliness, not taking meals, or not taking their medications. I have seen when you will be able to see these patients, when they're depressed or when they have a mental illness, they don't take their usual medications. And sometimes they don't take medication with the purpose of ending their lives. So if you see any of these are urgent referrals. And also, as I said earlier, if someone refuses acute treatment, which is life-saving or limb-saving, so it's very important to refer urgently. So I thought that I need to say a word about delirium. I know that today morning you had lectures on delirium, but even though you had lectures, I wanted to mention some things about delirium. It's a very common presentation. It's like in a acute medical setting, it is about 20%. It means that 1 in 5 patients will present with this acute confusion and stage. So this delirium is very common with advancing age. And if there is pre-existing cognitive impairment, such as learning disability, dementia, delirium is more. And also post-surgical conditions. And if a patient is in the ICU for a long time, they can come with delirium. And I know that the patients with hyperactive delirium, they get attention because they are shouting, trying to leave the ward or restless. But hypoactive delirium, we have to be very good in identifying hypoactive delirium. In that, you might notice some patients may be looking over-sedated. And if you look at the drug chart, and if there's no such medication which is causing sedation, you have to have a hypoactive delirium in your mind, because it is something we miss a lot. And it is a commoner form of delirium. Therefore, if you see them, we can collaboratively work on that patient and to see why this patient is getting this delirium. And together we can help him improve from his delirium. So I think the previously madam has gone through this list of causes for delirium. So why delirium is very important? Because if someone has delirium while having a comorbid medical illness, the mortality rate is high. And also, if someone is having delirium, hospital stay will be prolonged. As doctors, we are responsible for discharging patients as early as possible to go back to their families. We know there are economical problems and social problems. Maybe he is the caregiver of the family. So we have to always be keen to cure or help the patient improve and discharge as early as possible, because he or she has a lot of other responsibilities, commitment at home or society. So if the patient is having delirium, there is a risk that the patient might need to be in the hospital for a long time. And physical recovery gets slower and less optimal. They might not recover to the best levels. And as you all know, delirium is toxic to the brain. It means that if someone has delirium and it goes on, it damages brain cells and risk of developing dementia is high. Therefore, it is our duty to recognize delirium and refer to the psychiatric services, and together we can work and improve his condition, the patient's condition. So I think I need to talk about delirium tremens also. If we talk, as we talked about delirium, delirium tremens, you know, is a condition which happens in alcohol withdrawal. This is severe withdrawal. So, you know, it occurs in the second, third, or fourth day of withdrawal. So we need to liaise with the psychiatric team and treat accordingly. And if in a patient whose alcohol history is there and delirium is prolonged even after 5-6 days, we always need to look at the other causes, such as could be head injury, could be liver failure, could be hypoglycemia or infections. Always look at the other causes as well, other than delirium tremens. We might treat for delirium tremens, but the cause could be something else. So always talk to your seniors and get the psychiatry opinion as well in managing these patients with delirium. And I think I need to talk about alcoholic hallucinosis also. I think previously you got lectures. Alcoholic hallucinosis also, please refer to the psychiatric services for earlier treatment. So why treating delirium? How we are going to treat delirium? So it is mainly non-pharmacological management. Psychiatry team will help you in arranging non-pharmacological management. It is easy. It's very easy to start on psychotropic medication and control the behavior, but the risks are there. The main risk is patients very common to get aspiration pneumonia. If we load these patients with psychotropic medications, it's very common to get aspiration pneumonia and the prognosis will be lower. Therefore, non-pharmacological management is very important. If you need any help, you can always talk to the psychiatry team and get help. So these also can lead to behavioral disturbances other than alcohol, such as cannabis, amphetamines, and recently more and more patients come with these behavioral disturbances, and also multiple drug abuse and pregabal independence. So they might get admitted to the ETU. So in the acute management of these patients, you can get the help of the psychiatry team. Those are the urgent requirements. And let's see about the non-urgent, but still important referrals that you need to make regarding the optimal management of these patients. So as you all know, patients with long-term physical health problems, there is a high chance that they can get comorbid psychiatric illnesses such as depression, such as in epilepsy, rheumatoid arthritis, or carcinomas, diabetes, and CKD. Those conditions are associated with multiple social and psychological disturbances. So it's very common to get psychiatric complications. Please refer them. It's very good to refer them early to prevent complications and also optimal management of these conditions. And also don't forget about the caregivers of these patients. Because, you know, it's very difficult to manage someone could be with dementia or long-term physical illness like carcinoma. The caregivers might go into a burden. Caregiver burden is there, burnout. So please look at the caregivers also. If they have any psychiatric difficulties, please identify and please refer to psychiatric services. And as I said earlier, there are a lot of medically unexplained symptoms. After doing some initial investigations, if the patient does not have, and also history is very important here. You have very good training in neurology, medicine, and other specialties. So if the history doesn't tally with the medical condition, you can discuss with your seniors and refer to the psychiatry unit, because it's a very common condition to have these medically unexplained symptoms. So always respect these patients. Sometimes referral to a psychiatrist will be very stigmatizing, and patient might be reluctant to come to the psychiatric services. So your approach should be very, very kind and also empathetic. The common way of explanation could be, yes, we have checked you for a physical illness and we could not find any illness, any physical condition, serious physical condition. That's something good about it. So it could be like if there is any stressful conditions is going on also, these symptoms could occur. So it's good to get the psychiatry opinion, and by saying that you can refer to the patients, always explain why you are referring. So we can look at whether there is any ongoing stressful events going on, whether it's psychiatric illness. So together we can work on these medically unexplained symptoms. And as I earlier also said, psychiatric conditions can present as a medical condition, such as depression, saying that some certain part of the body is not working, they are coming with nihilistic delusions. And a lot of patients come with pain disorders. So and also dissociative disorders. They come with some neurological symptoms, pseudo-seizures, or weakness of the limb, or sensory deficits, and also anorexia nervosa. This is not common in Sri Lanka, but now it's appearing, the cases are appearing. They might come with weight loss, so nausea, vomiting, diarrhea. So check whether these patients having symptoms of anorexia nervosa, bulimia nervosa. And if you suspect anything, talk to your seniors and refer to psychiatric side. And also, you know that these conditions have comorbid, the disease itself has psychiatric manifestations, like in SLE or hypothyroidism, hyperthyroidism, epilepsy. You know that post-ictal psychosis can occur, post-ictal confusion can occur, and inter-ictal psychosis can occur. And with HIV and syphilis, even though not very common, they can come up with psychiatric complications. And this is very important, as I always say, if there is suspicion that if there's any abuse going on, or bullying, neglect, sexual abuse, emotional abuse, or physical abuse, in addition to referring to the JMO, please refer to psychiatric side also for psychological support and further assessment. And this is a very common condition. Poor treatment adherence is a very common condition you will be seeing in the medical or the other units. Check why these patients' treatment adherence is poor. Could be due to passive death wishes or active wishes, or could be due to underlying depression or anxiety. So if you notice anything, you can refer these patients. And medication side effects. Medication side effects such as this prednisolone, if you are giving for a long time, they can come up with psychiatric symptoms. And levodopa, this carbidopa and levodopa, you know that they can cause visual hallucinations. And this is a very serious condition, neuroleptic malignant syndrome. If you suspect, discuss with your seniors. And serotonin syndrome and lithium toxicity. Lithium management, lithium toxicity. We can together work on these and we can help patients. And sometimes patients come with medical presentation, but to see if there is investigations done, and all the investigations might come as negative and sometimes positive investigation, repeated fractures or something. So the patient might have some gain. Patient or the caregiver might have some medical gain. So these, we call it factitious diseases. And also sometimes to get some legal help, legal compensation or anything that might, patients might feign psychiatric illness or a physical illness. So after referring to the psychiatrist, we can help in identifying these kind of conditions, whether there's any factitious disease or malingering. So this is also important. Important to diagnose, because sometimes we might get to a very uncomfortable position because of this legal or the other claim conditions. And I think today morning you must have got the lectures regarding the pediatric population. It is very common to get these physical symptoms because of some psychological disturbances in the child. Even in a very small hospital, patients, children come up with this abdominal pains, neurological abnormalities such as numbness or faintishness, chest pain. They sometimes, after the initial investigations, if there is any other physical condition, pediatrician used to refer to the psychiatry unit. And we see a lot of psychological disturbances, social difficulties, abuse. they come with these abdominal pain or physical symptoms. And even the children can have dissociative symptoms such as these faintishness, disorders in the nervous system. So even in the pediatric population, if you suspect, talk to the family and talk to the senior doctors and refer. And in the perinatal psychiatry, this is very important because we treat some patients with psychotropic medication. Sometimes if the patient is planning to get pregnant or in the first trimester of pregnancy, we need to alter the medication. Sometimes if you are working in the gynae unit or obs unit, you might see a patient who comes in the first trimester unplanned pregnancy or planned pregnancy, but without psychiatry opinion, but she is taking medication. So always refer to the psychiatric services and get opinion regarding continuation or discontinuation of this medication. And in all trimesters, it is very important to liaise closely with the psychiatrist regarding the pharmacological management and the suicide risk to the baby. And at the time of the birth, also very important regarding the what medication should the patient be on, and neonatal withdrawal symptoms, and after the delivery, how you are going to restart medication. So therefore, if a person with mental illness gets pregnant and you follow up a patient, always talk to the psychiatrist side, and closely continuous management together with the psychiatrist is very essential. And you know that after delivery, they might get maternal blues, depression or psychosis. And you know that suicidal risk, those things are very important. Therefore, please talk to the psychiatry team if you see any of these. And capacity assessments, as I said earlier, adjustment disorders such as in like mass disasters, maybe could be a accidents, road traffic accidents, or these floods or anything, and grief. These things sometimes maybe the patients will come with the medical complications after an accident or anything, but get the support from the psychiatric services in how to psychologically help them in the acute stages. These medications also is important. I know that you had lectures on these clozapine and lithium. So if you have a problem, you can always discuss with the psychiatry team regarding the optimal management of these patients while the patients are on this medication. So these are the areas that I wanted to cover. And if there are any questions, you can ask now. Or otherwise, I'm going to stop this at this point.
Thank you, madam. If you all have any questions, we can use few minutes to answer them. Please unmute and ask, or you can type in chat box. Thank you, madam. Yes. Right. So next up is a lecture by Dr. Anoma Jayasin, consultant psychiatrist at BH Mahiyangene on the topic of psychiatric illness during pregnancy and postpartum period. So, madam will join shortly. Just logged in there. Right. I've given the introduction, madam. You can start. I've given the introduction, madam. You can start.
Hello. Hello.
I've given the introduction, madam. You can start. You can start sharing, I think. Can you hear us? Hello.
Hello. I can hear you now.
Can you hear?
Yeah, I can hear you.
We can. You're not sharing it. Not sharing it.
Shall we start or do we have to wait?
I think you're not sharing it, madam. You need to share the presentation. Are you having a presentation?
I have a presentation, but the issue is it's in Sinhala.
That's all right.
Is it okay?
Yeah.
Should it be okay? I thought that it may be not nice.
Yes, we can see. You can start.
Okay, shall I start then?
Yes, please.
Okay. Okay, good afternoon, everybody. So I'm going to talk about psychiatric disorders related to pregnancy as well as arising in the postpartum period. So pregnancy and postpartum period is thought to be a very kind of a very positive period in a woman's life as well as a family's life, family concerned. But however, a lot of mental health disorders and problems are associated with pregnancy and postpartum. So we'll see about the pregnancy losses. The early pregnancy losses, that means the losses happening in the first 3 months of time, 3 months of the pregnancy, are similarly mentally affecting women to the pregnancy losses of later of the pregnancy. So this is a very shocking period to the woman as well as to the family. Usually this causes a variety of emotional issues. So usually this loss is associated with the grief and it improves with time. However, certain disorders such as depression and anxiety could last for a long time. So because of this, we have to have a follow-up, at least with the public health midwives. What is most important is this is just a miscarriage for us during our heavy workload, heavy work time during internship. Sometimes we feel that this pregnancy loss adds to our work stress. So sometimes we might tell, oh, another one, when we are going to take the patient to the theater. So don't make them feel that they are a burden. Help them, support them. If you can, just talk a little bit with them. So they will be able to find the hospital as a pleasant place, as well as their grief could improve a lot. So these are the statistics. It says that even if it is an unwanted pregnancy or during the early pregnancy loss, all these symptoms, all these disorders could arise in the woman. So later in the pregnancy and after the delivery, this period is a very challenging period because there are a lot of changes happening in the body. The hormonal changes, the body gets changed. There is a difficulty in tolerating all the stress during the household, and the postpartum blues are very common. This postpartum blues, we'll talk about it later. And then again, the postpartum psychiatric disorders occur during the first 3 months following the pregnancy. So out of those also, depression and anxiety are very common. So why do we worry about postpartum psychiatric disorders? Because the psychiatric disorders reduce the ability to function of the mother and her ability to have a bond with the baby. So this affects the mother-baby bond, as well as the development and the nutrition of the baby. So what are the risk factors? One of the main risk factors is the mental health history. So if there is a history, even before the pregnancy or not related to previous pregnancies, the depression, anxiety, and bipolar disorder are associated with relapses during the postpartum period. And also other psychosocial factors such as the impaired relationship with the partner, and also poor social support and continuous stressful situations in the life could affect the mental health of the mother during the postpartum period. So, for an example, if there is a woman who's taking care of the elderly mother and also a school-going child who is getting pregnant and delivers the baby, it will be a huge workload on her. So these stressful periods and a workload would affect the mother's mental health. So it is important to identify whether these mothers have psychiatric disorders, because we can manage them during the postpartum period if they relapses before the disorder worsens. Postpartum blues, as I told, it's very common. It can happen up to 85% of women during the postpartum period. So this behavioral change includes emotional lability, crying, irritability, feeling confused, anxious. So this is the negative side. Uncommonly, some women might also show an elation. So this postpartum blues is common, as well as we don't take it as a disorder, because usually with this, or even those behavioral changes and emotional changes are there, it doesn't affect her psychosocial functioning. So if a woman having these symptoms during the postpartum period, but still working and attending the household activities and the baby, it's not a disorder. So usually with providing of a good social support, these symptoms could subside. However, if these symptoms last more than 2 weeks, as well as if the symptoms are severe in intensity, we have to intervene. And then the postpartum depression. So postpartum depression is the most common disorder we see during the postpartum period. So this depression is similar to the depression happening during the life, apart from postpartum period. Usually there are negative thoughts, lack of sleep, appetite, difficulty in concentration, irritability. So usually the depression during the postpartum period is the negative thoughts are concentrated on the baby. So the mother thinks, what would happen to my baby? This baby is not sucking properly, or the baby might have an illness, or that the baby is dysmorphic. So with all these symptoms, the continuous low mood, sleep disturbances, lack of energy, the marked anxiety could progress to suicidal ideas and committing suicide too. So usually this is postpartum depression could be seen up to 15% of mothers. This the onset is usually during the first 2 to 3 months period, but it could even happen during the first few days of and first few weeks of the postpartum period. So if there is a history which is not related to postpartum period, this risk is increased 25%. It means if there is a woman with the history of depression, there is a 25% high risk of getting postpartum depression. And if there is a postpartum depression in the history with previous pregnancies, the risk is increased to 50%. So just keep in mind, if there's a history of depression in this woman's life, there is a high risk of relapse during the postpartum period. So the postpartum depression is screened with EPDS scale. Usually, if this score gets more than 10 marks, there is a likelihood that this woman could be depressed. And the postpartum, we'll go to the postpartum psychosis. Usually this happens during the first 2 weeks of time. However, it's possible to happen during the first 3 months. Compared to the other disorders, this is a psychiatric emergency, and the changes are shown very acutely as well as in a severe intensity. Usually, what we say is there is elation, or maybe very the woman might present with very low mood, and also disorganized behaviors. Maybe there may be delusions, there may be hallucinations. Hallucinations are hearing voices or seeing things when there is no stimulus. And delusions are, there are those beliefs are unfounded. Usually there is no reason for the belief. Sometimes the mother might think the baby is possessed by a devil or some unseen agent, or sometimes mother might think that the baby is with an incurable illness. So the guilt, the fear, auditory hallucinations, delirious symptoms, and confusion are the common symptoms, but there may be even increase in happiness as well as overactivity too. So the postpartum psychosis is a psychiatric emergency. We can't wait and see. We have to do the basic investigations to exclude delirium, which is also common during postpartum period. And when the medical conditions are excluded, it's very important to give adequate psychiatric support and treatment for the mother. Because when it comes to postpartum depression and postpartum psychosis, there is a risk to the mother as well as the baby. These risks are in depression mainly, even with postpartum psychosis, where mother feels that she's not safe and fearful, she might think of ending her life. So if this happens, usually mother feels that if she is not there, who would take care of my baby? So as a measure of avoiding the baby facing hardships in the life, mother might think of taking the baby with her. So we have seen sometimes these postpartum mothers trying to commit suicide while harming the baby. Harming the baby is usually an act of sympathy. So the most important thing is identifying this as early as possible. So how can we do this? When you're getting the history, just ask one question from this mother during the antenatal visits, maybe not even after the delivery, whether she has had any psychiatric disorders or any symptoms suggestive of a psychiatric disorder previously. So we can keep an eye on her, because there are a lot of mothers. All are screened with this EPDS score. However, we might miss. But in the ward, if we do this regularly, we can find out who are at risk and we can intervene. And also, the main problem is the stigma associated with psychiatric disorders. So we have to address the family too. When it comes to postpartum psychosis and postpartum depression, we have to tell the family these disorders are very common. And each and every woman is at risk with the hormonal changes, the workload, as well as the sleep disturbances. So, providing adequate social support is the mainstay of treating the mother. So, the family could observe the medications, and if necessary, they can bring the mother back to the hospital when there is the risk escalation. And we have medications which are not affecting the breastfeeding, and some medications are not disturbing the sleep. And also, the mainstay of treatment of severe disorder is ECT, because ECT acts very fast, it's very safe, and we can allow the mother to unite with the baby as soon as possible. So, without a delay, the mother can feed and take care of the baby if we go ahead with ECT. So, we have to talk to the mother and as well as the family about the disorder as well as available treatment. You don't have to go to a detailed explanation. Just a brief discussion would be enough, and we can look after the rest. So, is there anybody with any questions or anything? Anything to clarify? Hello?
Yes, madam.
Is there anything to clarify? Are the pre-interns here with us? Or?
Some on the Zoom, others are on the YouTube live broadcasting.
Okay.
You're asking a question, so you can. They are a little bit of muted group. They hardly speak.
The other thing we have to keep in mind is that the pregnancy and the delivery, they are not disorders. They are physiological events happening in a woman's life. So when they come to the hospital, we have to treat them very, we have to have the concern that these are normal people, and we have to talk to them empathetically. We usually don't like to come to a hospital. And sometimes our behaviors can negatively affect the mothers. Like, I know that you are working very hard during the internship, and you might be talking to your friends or the nurses while you are doing episodes or while you are delivering the baby. However, just talk a word or two with the mother too. Just ask her how she is, how she feels, and just reassure the mother. So This is very important in supporting the mother mentally. There's nothing much we have to talk about. If you see any changes in the postpartum period, there may be subtle changes, such as mother complaining she doesn't have enough milk flow, or the mother might be telling that she feels anxious. Mother may be tearful, or she may be in her own world, thinking, withdrawn. So these are the red lights that we have to see. If those are there, if you find difficult to elicit symptoms, further you can always talk to your seniors and refer the patient to the psychiatric unit in the hospital. So if they are unmuted, we can talk if they have any questions, or otherwise we can stop this. The other important thing is, sometimes you might see these women during the antenatal period, they are not attending the clinic visits, and they're missing the clinic visits. So before scolding them, talk to them and ask what's going on. There may be problems at her household. There may be domestic violence. There may be financial issues happening in the household. So rather than kind of scolding them for missing the clinic visits and scans, talk to them and see what's going on in the family too. So that may be a risk factor for the further missing of clinic visits as well as poor outcome of the pregnancy. If there are no questions, we can stop this, isn't it? Hello? If there are no questions, we can finish this, isn't it? Shall we?
Yes, madam, right. Thank you very much for madam for that informative lecture on on psychiatric illness during pregnancy and postpartum period. So that was Dr. Anoma Jayasinghe, consultant psychiatrist at BH Mayangre. So thank you, madam. So that concludes today's program on psychiatric session. So tomorrow we have a session by College of Medical Administrators, Hospital Management Litigation, and BSc writing. So do join by 9 a.m. tomorrow. So we are taking attendance tomorrow also. So we have taken the attendance of the Zoom logins. Right. Thank you. Tomorrow 9 a.m. Right. Thank you.